Breakfast is also available for those who have not done. So please, you can proceed for breakfast also.
हाँ ये तो इस लैपटॉप का ही है।
इसका चेंज करना है, इसका चेंज कर दो,
इसका चेंज कर दो।
बट अगर मैं इसमें जैसे वो दे रहा हूँ ना नाम और ये फोटोज वगैरह बहुत छोटा हो जाएगा और वो पढ़ा नहीं जाएगा, इसलिए मैंने
बोल रहे हैं हमें दिखते नहीं रहा कि जो इसका बड़ा इंस्ट्रक्शन है उसको लग रहा है कि पीछे उनको दिखा
I would request everybody to please be seated. We are starting with the next session, the panel discussion. Shubham, please call everybody from outside. Everybody please settle down. We are starting with the next session. Okay, Atri.
I welcome back everyone for our next session. So I request everybody to join us for a panel discussion on digital twin technology in healthcare, its challenges, solutions, and the crucial role played by digital healthcare technologies in advancing the healthcare system based on the various challenges posed and how we can develop technologies to address them. For the first panel discussion round, we have with us Dr. M.C. Mishra, Ex-Director, AIIMS, New Delhi. We have Dr. Ashok Puranik, Executive Director, AIIMS, Guwahati. We have Dr. Veer Singh Negi, Executive Director, AIIMS, Bilaspur. We have Dr. Madhavanandan Kar, Executive Director, AIIMS, Jodhpur. We also have with us Dr. Dheeraj Shah, Director, National Institute for Family Welfare, New Delhi. I would like to request all of you to be here with us on stage so that we can begin with the panel discussion. So we
आप ये ना बाद में माइक ले लेना
मैच्योर हो तो फिर शुरू करो अभी कितना आपकी होगी ओपीडी पहाड़ पे तो हिमाचल के लिए तो ठीक है, और थिएटर में काम कर रहे हैं.
I welcome all the experts here.
गाँव कहाँ पड़ता है? आपका गाँव कहाँ पड़ता है? अच्छा, आप उत्तराखंड से हो. यू आर नॉट फ्रॉम हिमाचल. आई ऑलवेज थॉट यू आर फ्रॉम हिमाचल. ओके, कहाँ पे उत्तराखंड में? अच्छा, लेस डाउन. बट terrain is same. Terrain is same. हिमाचल and उत्तराखंड का.
I thank all of you for being here and spending time from your busy schedule. So, as you can see, we have gathered esteemed professionals from industry, academia, government officials, and investors for both the technology demonstration part that we had in the morning, and as well as for the panel discussion and the roundtable discussions that would follow later in the second half. So our aim here is to foster impactful networking opportunities and expedite commercialization prospects. So Professor Mishra, I would then like to understand from you first, what are the primary challenges hindering the widespread adoption of digital health solutions in India, and what steps can be taken to enhance the digital health infrastructure in India, ensuring it's robust, scalable, and accessible across diverse demographics, looking into the diversity that we have in our country?
I think the first and foremost is our own ignorance. Those who are working in medical field, particularly in clinical medicine, because in India we are all overwhelmed by the number of patients we treat in public hospitals. So we tend to get very little time to think new and do something new. I think that is a huge challenge for all of us. And that is where, if now it is happening that all of you from the engineering side and technology side are approaching us. If we had this maybe 25 years ago or 30 years ago, we would have made some progress. But now it has begun in this era, so it will take its own time. We should give that much time. And I would also say, as I was discussing with some of the young, energetic, all the boys and girls who have developed several solutions to health problems, that you have to spend some time, whether a day, 2 days, 1 week, 2 weeks, depending on what is the problem you are looking at, understand from within and shadow the doctor, like you can shadow Dr. Deepak Agarwal to his critical care unit, to his operation theatre, to his outpatient, and then, because the solutions we have to identify, the problems we have to identify in public sector, because still whatever we may say, we have a very robust private health care, but that can only be accessed and afforded by a small segment of population. Large population still will be dependent on public hospitals. Whatever we may be saying and boasting and doing that. So solutions have to come there, that how we can make experience of an average person like me coming to AIIMS, coming to Safdarjung Hospital, coming to RML Hospital, or coming to AIIMS Rishikesh or AIIMS Jodhpur, his experience is positive and it's friendly. How we can do this, having large number of patients, that's a challenge. And that's what we were trying to do at AIIMS also. what I always say, large number of patients is a bonus for us. It's our USP. We should take advantage of that rather than complaining that, look, these are so many people. How we can make use of that large cohort of patients coming to us, asking no questions, you do whatever you like to do, but our responsibility is that we should not be harming any patient. That's the bottom line. Whatever segment of society that patient comes. And that is the beauty of aims, which I have observed, having spent 37 years. If a patient is admitted in a general ward, I will operate. My professors operated that patient. Not that we have left to the residents. So that is where the challenge lies, and we have umpteen numbers of problems when we are working with these patients for many things. For example, I think the clear example is a brain injured patient. This patient needs rehab for almost, some of them will require at least, I would say, 35% patients or 30% patients with severe brain injury would require neuro rehabilitation for life. They may not, none of them may be ever independent to look after themselves. Either the family has to look after them, or the community, or the nation. Now in India, we do not have a system like developed countries where the state takes care of these patients. It's the family who has to take care of this patient, who was the breadwinner before he got head injury. So his earnings, his income, the family income has gone down. So you can imagine this, how huge it's a problem. So can we develop some solutions for this in the community? There are non-governmental organizations who are willing to take some of these patients and look after them, give them palliative care or supportive care. As I think just now we were discussing about bed sores, then it becomes a huge problem in these places. So how we can prevent them rather than bed sore happening and then we are treating because there is no treatment. Treatment would mean again going back to the hospital, getting operated, which may not be easily available for them. And there is a cost attached to it. Whether it's public hospital, ultimately it is costing taxpayer. Whether it's aims Bilaspur, he is getting treatment, or aims Delhi or anywhere. It's the taxpayer who is paying for this care. So can we reduce that morbidity? Can we reduce hospital stay, which we have done? Can we improve quality of the treatment in the hospital? And we have done that. I think Deepak would vouch that we have done this quality improvement programs. Without putting a lot of resources, we could improve. For example, Dr. Bhui worked in our trauma center, how to reduce time for a patient to stay in emergency department. And we could do it without adding any resource. We brought it down from 4 hours to 1 hour with the same infrastructure, with the same manpower. So I think it's a continuous process. Quality improvement is a continuous process, and we must identify problems which are more prevalent in a hospital population and find solutions for that. Simultaneously, you can also work towards what you feel it's an important problem. I am not saying that you don't work on that, but go for low-hanging fruits first and then go for the next. Thank you.
Thank you so much, sir. I just have a follow-up question. So you just mentioned about the fact that how aims is beautifully managing to manage the imbalance that happens between the number of patients, and often there's a limitation in the resources available, the doctors available. You just said that how beautifully that is taken care of. And you also mentioned that it's very important for us to then reduce or predict the risk factors early so that morbidity rates can be reduced, right, and quality can be improved in the healthcare sector. So according to you, how do you feel technological institutes like IIT Indore and other technical institutes, and especially technology innovation hubs like Drishti CPS Foundation can then play a role along with institutions like aims to cater to these problems that you just addressed?
I think we can identify which patient do not need to come to the hospital which patient we can follow up even at home after their treatment at the hospital, at a respective hospital, so that the hospital numbers can be reduced. Because at the end of the day, anybody who is coming to the hospital, we need your time. So how can we do that? For that, we can have, and also those patients we can call by establishing some kind of a reminder. As you see, we get from the airline. You see, airline gives you reminder, your flight is so and so time.
So
Can you
follow
be there at the airport 3 hours in advance or 2 hours in advance? The same thing can be done for this also. And then we also see what is the capacity, how many patients can be seen without basically inconveniencing the patient. So the only problem with India is still in the public hospitals that people do not like to be given appointments, say after 2 weeks, after 3 weeks, or 1 month as happens in US with a much smaller population. When they think that they need to be seen by a doctor, they would come. So that is the psyche of people also have to be changed with maybe creating more awareness about this. Look, if you take appointment, you will be better served at the hospital, even at a public hospital. It is possible that limited number of patients, whenever we get, like now I am on private side, so I can tell you even a minor problem, patient takes my 15 minutes, half an hour. While in aims, maybe a serious ailment may not get that much time from me, because I know I have to see another 50 patients or 40 patients. So some kind of a system we have to evolve, and that is where digital technology can really basically enable. By creating awareness about it, and lot of things can go on digital platform for their, if we want patients to carry on their healthy life, support healthy lifestyle, how they can do that. That can also be, they can be informed. And anything going from the hospital, people take it seriously. The same thing available on television or on YouTube may not be that much. People may think, पता नहीं किसने डाल दिया है, क्यों डाल दिया है ये, इसका कितना worth है, और है भी. There is a lot of junk on WhatsApp, on YouTube, so they cannot differentiate between good or bad. So that is where technology can enable a lot of reducing waiting times, reducing numbers in the hospital, and also by reducing waiting time and selecting those patients and segregating those patients who need urgent treatment, those who need can wait, those who can be treated on outpatient basis. So I think technology from the world they enter, from the time they enter the patient is important.
Thank you so much, sir. On a very similar line, Professor Negi, I would like to then understand from you.
I would only add that now we have Dr. Kar sitting, Dr. Negi sitting here, Dr. Ashok Puranik also I saw, he's here. New aims should go for complete digitization from the beginning. What difficulty we are facing at this aims in digitization, it is being attempted, I would say, for 40 years. And we are not yet there. Computerization, for example, our hospital records. So new aims, like institutions, can do it from the word go.
Thank you so much, sir. Professor Negi, then how can digital healthcare ensure efficient and effective delivery of tertiary level, mostly if I say patient-focused and patient-directed healthcare services, ensuring quality as well as patient safety? So something very parallel to what Professor Mishra was just mentioning.
Professor Mishra has already elaborated on these points. Just for the repetition's sake, we are a very large nation, very big population. Most of our people have, they are not very well economically sound people. The out-of-pocket expenditure on healthcare is quite large, and many of the people during COVID, they went again into the poverty because of lack of many factors. I mean, lack of occupation and because of expenditure on their healthcare. So the healthcare, when we call a person to be healthy, or when we say that what are the health services, they are preventive, promotive, curative, and rehabilitative. So prevention, as sir has already said, prevention in the form of first educating the people, making them aware of good lifestyle. Technology, of course, can help in that. Promotion, the same aspects, the promoting to all the population, that not only includes the patients but general population also. And then comes the curative component. But here I would like to add that why does a person fall ill? A person falls ill because of, there could be some internal factors, but there are external factors also, probably, which are more important. So if the industry makes more fuel efficient cars, less polluting things, and more efficient systems, so that the healthcare, the person will not fall sick, and of course the newer technologies will help in efficient delivery of the system. Then comes the curative aspect. As you said, curative aspect is not limited to the tertiary care hospitals. It starts from the primary care itself. So and the cure starts only when we diagnose something. So first is the diagnosis at peripheral level, and diagnosis, then secondary and tertiary care level. Now the Government of India has started the program for non-communicable diseases, where these technologies are being used to diagnose hypertension, diabetes at the periphery. Even now the technologies are available where the X-rays are also can be taken, and the data can be in real time transmitted to a center where they can be diagnosed. So these are the technologies which is making the life easier, because tertiary care hospitals, as sir has said, that they are overburdened. So if there is overburden, there is likely that the patient care may suffer. So one is to reduce the burden on them. Second is to improve the efficiency of secondary or tertiary care level. So primary care diagnostics, many of the things probably can be treated at primary care level itself after diagnosing them. And second, what sir mentioned was the rehabilitation component, where the people after coming to a hospital need not come to the doctor again and again. So that what you call the follow-up visits, if that is already happening. So if it can be somehow made more elaborate, or the person need not come again, and it can be through video conferencing or through digital technologies, if the diagnostics can be done, if the advice can be given, or if the policy decisions can be taken, that the treatment which is given online, that is valid. So that is going to solve many problems. Then comes the secondary or tertiary care, where the problem of lack of resources, because the healthcare still has probably 1.5% of the GDP is spent on healthcare, which is meager as compared to other economies which are much smaller. Another thing which I'll mention here is we are a very unhealthy society. Our food, our habits are quite unhealthy. So it's the explosion is already happening about diabetes, obesity. It's going to get worse with time. So what we need in the hospitals is the early diagnosis, and then their treatment. Treatment means the efficient delivery, like the waiting time has to be reduced, the proper treatment has to be given. So it depends on the specialty, then what kind of treatment a person requires. If somebody requires surgery, probably that person will need a newer kind of tools to reduce the surgical times, or to reduce the morbidity or the complications happening afterwards. So, but even after a person with medical or surgical problem, if gets treated, some of them cannot be cured. Then comes the rehabilitative aspects. So rehabilitation of many people, many diseases, as sir has mentioned, some of them require long-term rehabilitation, especially trauma people, especially people with neurological disabilities. They will require long-term rehabilitation, and especially in cases of accidents where the person was perfectly healthy and gainfully employed, sometimes the only person in the family to earning for the family. So if the person is not coming back to normal, becomes a burden not only to the family, to the society also. So, or if we can develop technologies, technologies are available, if we can integrate those technologies with healthcare, so that these people can be the rehabilitation can be faster, it can be effective, more efficient, then probably the healthcare can be improved a lot.
Thank you so much, sir. So you just mentioned how how digital healthcare can actually empower patients to take a more active role in managing their health, maybe, right? So I think before we move on to our next guest, can we take some audience questions if anybody from the audience wants to ask our experts something?
Yeah, hi. Good morning. This is Jose coming from IIT Bhilai. I just have a very specific question which I experienced as a problem. See, we as a technologists always try to solve problem whichever is coming on our table. And recently we were trying to work on one problem, and where we are trying to use a new material as a implant. And when I say new, it is new to India, but it is already started its usage in US. But then we found there are restrictions when we wanted to try that. So I just wanted to understand, sir, from you people that, how easy for us when we wanted to implement certain technologies when it comes specifically to, medical domain.
What was the new?
Okay, so if I can give some details, it is on maxillofacial surgery. The current material that are currently being used are titanium-based alloys.
Yes.
So we wanted to use a what is it called? We wanted to use magnesium alloy, which is biodegradable alloy. Right, so these are like biodegradable implants, so you don't need some secondary surgery to remove the implant if it has to be removed later, because it is directly assimilated within our body.
No, but if we want that implant to be there forever, then
we cannot use it.
then you cannot use it.
Then we cannot use it. Yeah.
So only when these need to be removed, then only you can use them.
Yes,
So
sir.
what was the problem?
The problem is when we wanted to use it. Okay, when we wanted to try it, we were told that it usage of new material requires a very lengthy approval procedure.
No, it will not be needed. I think it has to be seen in the some kind of an animal model, that how it is working before we can translate it into clinical. That's the only difficulty it will be, and for that, naturally for animal lab you need to have a license to work on small animal, large animal, depending on what you would do. So not procuring the material itself. There was no problem in getting the material.
No.
So you have to first develop a model, non-human model, whether it's animal, and it will be animal, live animal, and see how it works, and animal which will survive the implantation. Dr. Raghu, you would like to say something?
I can sir answer this.
His question was, it's already approved in the US.
Yes.
FDA is one of the most stringent approval processes. And
No,
he said
that is initially there was the guidelines why is it preventing, but now this is you are facing with the transition. ICMR has given very clear guidelines. This is you can use. But you have to directly, like you technical people, you are thinking that you will directly use in human. This is not allowed. Anything you have to go first, the similar, like mammalian body, you have to do the clinical trials. Clinical trials goes in phases. All these things has been proved, then you will shift to the human trial.
If it is,
This is it.
yeah, but if it
It
is,
was not initially, guidelines were not there to supporting these things, but now there's a lot of things, sir. We are using, recently passed the biodegradable biliary stent. That has been cleared by ICMR doing for the clinical trials. This is not difficulty, but don't think that US will accept here. Even ethnicity is different, even now the Indian government also clearing, he have to clear here the ethical issues. Then this looks like difficulty. There is no difficulty. Now ICMR guidelines has cleared many things that it was before.
and
So
if you
clear.
can produce enough evidence that it has been used and safe, then ethical clearance is what would be needed. Your institutional ethical clearance on the basis of published evidence.
Sir,
Even if that may be, have been done in US or anywhere else, it doesn't matter. We are using all these ortho implant in India, which are imported without any difficulty. We are using them.
Sir, I'll just add to this. It's what, sir, you have said is absolutely right. There is now a standard regulatory environment in India, parallel that in all Western countries. I think that's a good thing. If you want to develop a device, there are two things. Either you're importing any device, same material, which has been FDA cleared, you need to submit the same process to CDSO. You will get a manufacturing license or import license and you can start using it. Same thing. That's called a predicate device. The second thing is we want to develop something de novo. Then you will have to go to a lengthy process where you will get, as sir said, ethics clearance.
Like the vaccine development,
Yes.
we had the same.
Same thing. You will get to need a ethics clearance along with CDSO research approval, only for research purposes where you can do it in a clinical trial, following which you will again apply to CDSO for a manufacturing license and then use it. So this is a standard regulatory process.
This lengthy process gradually they are decreasing. We are starting many things. This has been very clearly.
Namaste, sir. So I have a question on, so when we are discussing about the digital technology implementation, I want to know your views on what sort of policy things that Government of India needs to catch up. Like some of the things that I see is digital data policy, which is still ongoing there. We still don't have an AI policy. There are more than 400 to 500 AI devices which are present in the market, but we don't have a regulatory things to cover it up. And also in terms of, the data that is coming from hospital to hospital, like from aims to another government hospital, the data interoperability is also is an issue. Even though the patients are given a medical record, it is not easy to kind of transfer it to another readable device or something like that. So I was thinking, I see a lot of big policy gap here, and I expect some answer as to what is the focus, how we are going forward.
This is a very good question. See, when we are going to any new devices, this is their guidelines. This is the same thing, the ethical issues are there when you are interpreting different data in our healthcare. This is gradually it is evolving. Lot of things has been already answered, but now we are keeping data. This data has to be very clearly evaluated. There the system is there. Each institute they have being ethical committees. We are putting their data. There's clearly these models we have seen. Like we are felt in 2002 in aims Delhi, IRCS, we started the database. It was not available in whole India. That time we developed this thing. We are using in our thing. We developed what sir was telling, evaluated the quality. We evaluate, we audit ourselves, we evaluated these things. See, that cannot be accepted by all. We cannot put it others because each department, each institute different. Therefore, now the policies are changing in government. They are accepting after Honorable Prime Minister giving the digital India, lot of things are coming. But this legal issues still pending many issues because the feedback system is not so robust. Gradually, we are putting each institute, now all new aims what sir is telling, they are compulsory to adapt HIMS system digital. We have done in Bhubaneswar, in Jodhpur, totally not paperless, but gradually going to paperless, starting from the patient entry to discharge. This is already started. But few things we are facing, this we are putting back to the ministry and they are modifying the other thing. This is not one day we can put these things, ethical clearance will be done. This is on the process and lot of things has been done. People don't know. This is the system. I will add things, sir, from beginning what you are asking, the challenges for digital implementation in healthcare. Last, I have been involved in 2002, my residency till date. The most important people, medical professionals, they know. I know, but I cannot put because we are overburdened with patients and our accessory means this is the allied healthcare system is not so robust. In a whole India, there is no allied healthcare professionals training. We have to train them. Like the same thing, the nursing, the quality healthcare we can give when all communities will be involved. That's why the mandate for new aims is coming, community participation. Community participation is like technology, like common people. We take the feedback, we are putting in data, we are evaluating health technology assessment. That's why first time in among all aims, the Jodhpur aims developed one school of public health, which has been established outside US and School of Public Health only thinks will policy what government policies through aims will putting into community. All the data they are collecting. Another thing like satellite tribal health center, we are taking their traditional medicines, putting into data, we are evaluating like integrative medicine is coming in a big way. That's why the community participation is coming gradually. And this is support to the healthcare professionals, which was not possible for us, though we know it, but we cannot do it because our primary is to like point of care to the patient in the hospitals. That all things can be interpreted by your technology. Starting from patient following from their home to hospitals and taking them back everywhere the technology we need. We now started when it's a pilot project, that is a patient got the accident, from there ambulance is coming to hospital. That is taking up the GPRS, how far it is coming, where is the obstruction, where is the traffic jam, everything they will monitor. And within this period, they will come to the emergency. This is the technology help. Now the satellite is there, GPS, everything. We have to only register in the things. And telemedicine, we are monitor each patient to come here. We are putting interventional stroke therapies. Within 75 patients, they survived from the stroke because this monitoring system. Right time, right position, right here. You have to monitor everything. This is by digital. Everywhere we need the digital fortification because the patient load is so much and we are so few. We have to take that, but these ethical issues are there. This what we are facing problem, we are noting down, we are putting, can we do it? Then we have to take permission from the ministry. Like anything like cyber crime, you know, all data will go outside, ministry don't want. We cannot share everything with everyone. If you will come, I cannot give data. We need that authentication, that regulatory, this we have to share the data. Like ABDM, now after a few years you will see all patients' healthcare digital system will be, there is a single card. You will go with like credit card, anywhere you put the card, you will, every data you will come. That's why no need to take with the files, this already started. These are the bigger things coming gradually, but we need everyone's participation, support system. And regulations are going on and ministry is taking very much care of this. And this is the depending on the feedback, we are taking this.
Yes, please. Mike.
So, good afternoon, Gunjan here from Senior Citizens. So my question is specific like nowadays most of startup and within healthcare, we have a technologies ready to available, ready to market, and some of them are already in market. But when we reach out to government setting or any hospitals, when we ask them, can you install the product or can you buy the product from our startup? They say we cannot buy it. We say why? Then they say it should be on a GEM portal, and startup, most of the product is not available on GEM portal. So what would be on your thought if any hospital, any government setting to buy our ready-made product and technology? So what is the best one? Can you share your thought? And sometime we go to the purchase or maybe the specialty department, they ask you go to this department, they ask you go to this. Ultimately product will not install. And finally when we came to know, it's already imported product from outside the India. And the same specification, same product is not buy from the Indian products or maybe from startup. So please share your thoughts so we can.
Yeah, that's a very pertinent question for all new healthcare systems, especially in new AIMS we are facing. This one policy has decided by the government that's Make in India. Make in India means we have to promote our own technology, but simultaneously when the healthcare things comes, we need always things of the quality healthcare. You people look into AIMS in different level, because we have to maintain that level. How will you maintain? You cannot take the like rudimentary, just you start the one equipment, we will take it and I will give that care. It's not possible. I should first convince that your equipment you will giving me. Like simple example, I'm giving cutlery machine. So many companies are making it. Everything, their lateral spread. So many technical things are there. Then any things I have to be doubly sure before taking your equipment to use, because already the standard of care is there. For that purpose, Make in India is coming, and this is the transition. Government is making in GEM portal. GEM portal not compulsory for everything. This is not everything. We have to put you should approach the right person at the right time in the hospital. If you will go and ask the only procurement,
Dr.
they can do.
GEM portal,
It's not compulsory.
no, it's not compulsory, but you will find it easier
Yeah.
if something is put on GEM, you can buy.
Yes, sir.
As
Yes, sir,
AIIMS
he
Jodhpur,
just
he can buy at AIIMS Bilaspur.
Sir, he is putting, why the GEM portal nahi hai, to hum nahi.
No, no, but GEM portal also, to put on the GEM portal is also not easy. This is what I have learnt. There is someone who is making mannequins and I have been asking him to put on GEM portal, sir मैं try कर रहा हूँ, वो डालते नहीं है उस पे. ये भी problem है. GEM portal पे एक बार पड़ गया तो आपके लिए आसान होता है. फिर government institution can buy, private there is no problem. They can buy from any source. But for government purchase, if it is on GEM portal, then it is easier for them to give you order for the government institutions. That's why it is, you try and get it on the GEM portal if it is possible. Because they have a process, tendering process, they go through that and then put up on the GEM portal with a price. So they can, AIIMS Jodhpur, AIIMS Bilaspur, AIIMS Delhi easily can buy that. That's the problem with, in government we have a tendering process, we cannot shortcut that. That's a huge problem, and if there is a Make in India thing, naturally that will be preferred. But again, as Dr. Kar said, quality of that product also has to, if not match the imported one, at least close to match. If it is not different, so that is where there is a little problem in healthcare, the Make in India versus foreign make import. We all want, I've been asking whenever I used to go to CII meetings or SOCM meetings, I would always say, all of you, what you are doing, find it easy to import and sell and take commission. It is always difficult to manufacture a CT scan, MRI in the country, but somebody has to do it. If China can do it, why can't we do it? So that is where we are, and I am sure in coming times that will also be possible.
Sir, I can share one example. This is now recently India developed the MRI machine. Like for us, like that mindset is there. This is like, oh, India is developing. This means some quality issue is there. Then I closely associated Professor Jagannathan, who was retired from here as NMR HOD. He is involved in that MRI machine development. I have worked very closely with him during the research. I know the quality of that man. Then when I asked, sir, what is the quality of that MRI you are producing, and they're telling this 1.5 Tesla in the market. So, Dr. Madhav, this is far better than the West, because two things. One is that claustrophobia will not be there. We are making the whole bigger size, and quality is much better than 1.5 Tesla available we are taking outside. But people are that mindset, because it's an Indian product, the quality will not be there. This is the issue. Who will clear this issue? Because I formally associated with that person, they know. This is clear. Yeah.
Not allowing to buy imported
Yeah,
ones.
this imported one. That's why you put your products into GEM. For government setups like in UMs, sir, telling, for us it is very easy to take from the government, because government should have some regulations. No one can put everything everywhere. But you are telling from your point, like 5 people tomorrow come, among competition will be there. Then how we will choose? That is the GEM portal, the same tender is there, but easier to procure for the government hospitals.
I also want to add to this. Industry always, of course, wants to develop a new product and to bring it to the market at the earliest. Whereas we, the health professionals, we look at the, what we call as human safety first. Because right to life and right to health is enshrined in our constitution. We have to provide it to everybody. And doctors have a mandate that first thing is they should not do no harm to the, should not do any harm to the person, and then cure and treatment will follow. So that is why all these regulatory guidelines are there, which you have to fulfill. You have to go through the market clinical trials, and then you, in Western countries, sometimes it takes up to many decades for a product to come to the market from the inception stage. But times have changed now. After COVID, development of COVID vaccine, probably things have become much simpler, much easier. And we do hope that in India, that is also going to happen sooner or later.
Right. So, as we navigate wonderfully through the challenges in the widespread adoption of digital healthcare, I would like to then understand from Dr. Dheeraj here from National Institute of Family Welfare, how can, to what extent rather, can wearable devices and continuous monitoring technologies contribute to the ongoing assessment and management of patients both within and outside the hospital setting? Why I am asking this is we have so many technology developers here who who are building wearable devices, continuous monitoring apps. So what are your thoughts on this, sir?
Yeah, I think incidentally, we at the National Institute of Health and Family Welfare, we are having a training of central drug regulators on diagnostic devices as well as new diagnostic methods. And I think some of the issues which were raised, like regulatory approvals and the issues with procurement of all these devices, are being covered in that system training. You said that what role these devices and the monitoring systems can play in the hospitals and outside the hospitals. I think it's very important now, as very apparent from the start of this activity, that technology is here to stay. Technology is only going to grow. And we at NIHFW have a e-health division of the Government of Health by the name of Center for Health Informatics, where we build and we design all the e-health applications of programs of Government of India. So Government of India is already doing a lot of effort, putting lot of inputs into connecting the hospitals, connecting the health system, whether it is the primary healthcare system. We saw a stall of Ayushman digital mission, and whether it is hospital, HMIS is being made mandatory for newer aims, newer hospitals. So government is doing lot of effort, and the monitoring system, as the applications and the devices, they are in place. You need to put the data in. The challenge there is promoting the use. How to promote the use, the thing is already there, application is already there. How to make people, how to make it mandatory for the healthcare professionals to download it on their systems, on their mobile, so that it is used and the data could be provided to the government healthcare system. There is a, I think then there is a reluctance on the user side as well. People do not want to, as was made apparent, people do not want to put their data into the digital devices. They just want to continue with the paper and pen. Because of the various reasons, they think that it will take more time. But most of the people are thinking of short term. In the long term, all these data input into these kind of systems like HMIS and the electronic record system, it's going to help in the long term, so that next time you don't have to take all those details from the patient. You just click and find out the details, what is the history, what all hospitals. Ideally, the whole healthcare system of the country should be connected digitally. Means whether the person goes to a private healthcare system or a government healthcare system, that record should be captured on a by unique ID. Now we have unique ID for every citizen of India, Aadhaar number. तो उस आधार नंबर से क्यों ना एक मैंडेटरी बना दिया जाए कि जब वो किसी भी हेल्थ केयर में जाता है, चाहे वो प्राइवेट सेक्टर है, चाहे वो गवर्नमेंट सेक्टर है.
आभा करके कुछ बना है.
हाँ, but the thing is that आभा ID is there. The only problem is that how to make it mandatory, because still 80% of the healthcare is sought in the private sector. जो प्राइवेट सेक्टर में से भी अनरेगुलेटेड प्राइवेट सेक्टर है, जो कि किसी भी रेगुलेटरी बॉडी के अंडर नहीं आता है. हाउ, एंड देन देयर आर लॉट्स ऑफ एलाइड हेल्थ प्रोफेशनल्स. नाउ वी हैव एलाइड हेल्थ कमीशन एज वेल. सो नाउ द गवर्नमेंट इज मेकिंग efforts to regularize the systems which were even unregulated till now. In the Indian Allied Health Professionals Commission is also incidentally hosted in our institute. So now government is doing a lot of effort, but yes, it is challenging. But I'm sure that over next few years, with the government efforts, with the citizens' awareness, with the healthcare professionals' awareness about the advantages of use of technology, because if you just force everything on people, लोग कहेंगे कि अब हमें जबरदस्ती काम दे दिया गया है, पहले ही काम कम था, अब हमें ये भी दे दिया गया है कि ये भी डालो, हमारे पास हेल्प नहीं है. तो ये सारी प्रॉब्लम हैं. लेकिन जब एक माइंडसेट हमारा चेंज होगा कि हाँ ये हमें जैसे हम करना है, जैसे कागज़ और कलम यूज़ करते आ रहे हैं वैसे हमें डेटा को भी एंटर करना है। एक जो पर्सन फाइलें चला रहा था उस फाइल की जगह पे उसको एक डिवाइस दे दिया जाए जिसके ऊपर वो एंटर करना है। तो वो धीरे धीरे दैट माइंडसेट इज गोइंग एंड पीपल आर एक्सेप्टिंग द डिजिटल टेक्नोलॉजी इन स्पेशली इन द हेल्थ रिकॉर्ड मेंटेनेंस एंड एज फार एज द इक्विपमेंट एंड डायग्नोसिस इज कंसर्न्ड आई थिंक दैट ऑल इज मार्केट ड्रिवन। जब अपने आप ही जो पुरानी चीज़ ऑब्सोलीट हो जाएगी तो नई चीज़ जो टेक्नोलॉजी ड्रिवन है जब आएगी। इश्यूज आर रिलेटेड टू, जैसे किसी ने पॉलिसी गैप्स की बात की, यस देयर आर सम पॉलिसी गैप्स से ज़्यादा इम्प्लीमेंटेशन गैप्स हैं और उससे ज़्यादा procurement की जहाँ पर बात हुई कि yes procurement is difficult, government has a system, it has e-marketplace, but government is also dependent on feedback. Once the users give feedback that this kind of device is difficult to, or maybe this kind of AI based system or application we cannot use, it is a proprietary item, so they have to feed into the system, give the feedback, right feedback, so that the GEM system can be tailored to purchase that device. Make in India is there and Make in India has to be there to promote local. Yes, it जैम पे डालना इतना मुश्किल नहीं है। मैंने देखा है जिसको पता है कैसे डालते हैं वो एक एक दिन में अपना प्रोडक्ट उसके अंदर डाल के अगले दिन खरीदवा भी लेता है। आई डू नॉट नो हाउ डू दे डू इट, बट देयर मस्ट बी सम वे टू मेक योर प्रोडक्ट अवेलेबल ऑन द चिप. So there are solutions to the problem. Most of often it is mindset. जिसने आपको कहा होगा, आपको भेज दिया होगा वापस कि नहीं आपसे नहीं खरीद सकते, हमें जेम से ही खरीदना है, तो उसका भी एक माइंडसेट होगा कि क्या हम देयर आर, अगर जेम पे अवेलेबल नहीं है ऐसा तो नहीं होता है कि नहीं खरीदा जाएगा, तो उसके लिए भी गवर्नमेंट में सिस्टम है. गवर्नमेंट प्रोक्योरमेंट मैनुअल इज वेरी कॉम्प्रिहेंसिव, इट डील्स विद मोस्ट ऑफ द सॉल्यूशंस. और जहाँ पे सॉल्यूशंस नहीं है वो कहते हैं तब अपना काम करो, फिर क्यों, हम जब हम कह ही नहीं रहे उसको नहीं खरीदो तो आप खरीदो. सो देयर आर things happening and I am sure that over next 5-10 years gaps तो फिर भी रहेंगे, AI भी कुछ नई चीज आ जाएगी, फिर से वो जो गैप प्लग किए थे फिर से क्रिएट हो जाएंगे. बट कंटिन्यूसली प्लगिंग द गैप इज द वे द country should run. The human nature is that you have to keep on evolving with the technology and you have to catch up with the technology, and government system is slightly slow because it has to follow some processes, but ultimately government will do to make digital technology happen in hospitals, outside the hospitals when you talk of healthcare system. Thank you.
Thank you so much, sir, for sharing your insights on how we can work both inside the hospital setting and outside with the digital healthcare technology. So, keeping the time in mind, we have another panel discussion after this. So, I think I would like to thank all of you here, and I would request Aditya to present a token of gratitude to our experts here. I would request Professor Bhupesh to be on stage and felicitate the experts here. Sir, to Dr. Dheeraj, if we can. To Dr. Kar. And to Dr. Negi. Thank you so much, sir. So for the second round of panel discussion, I would like to invite Dr. Raghavendran on stage. Dr. Raghavendran, please. Yes. Yes. Dr. Shovik Maiti from IGIB, Director IGIB. Dr. Anshul Chaudhary, Program Officer, Bill and Melinda Gates Foundation. Himanshu Dhingra, a Consultant, National Health Authority. And Dr. Venkatesh Iyer, Head of Department, Pathology, AIIMS, New Delhi. I would like to invite Dr. Viren Sardana, Principal Scientist, IGIB, to join us on stage, please. I would like to thank all of you first to spare your time and be with us here today. So, as we were discussing already about digital healthcare technologies and scope here in India, so Dr. Raghavendran then, in the context of, I now want to dig a little deeper into specific departments maybe in the healthcare sector, and with your immersive experience in the trauma care. So in the context of trauma care, how can digital technologies facilitate remote consultations and provide expert guidance to healthcare professionals in areas where specialized trauma expertise may be scarce?
So that's a lovely question. Actually, it's already being done in India. So I just came back from AIIMS Rishikesh, and they have a telemedicine unit. So the telemedicine unit, they are able to beam pictures directly from the site of an accident. For instance, when they had the earthquake in Gujarat, they were able to provide on-site consultations. So there are many aspects of urgent trauma care that fit into the picture of global health or digital health. For instance, in trauma, there is something called a golden hour. A golden hour is the time during which it is imperative that the patient is stabilized and transferred for definitive health care, because beyond a particular extent, you cannot do much to save a human life. So digital technology is incredibly helpful in coordination. For instance, the system that we have in the US is a very, very well coordinated emergency medical care system. Every state has a designated area. Every level 1, level 2, and level 3 trauma centers are attributed to a particular area of injury. So for instance, if your accident happens on this side of the highway, you are likely going to go to this trauma center versus happening on the other side. So this is all digitally controlled. The other important aspect of this is also quality control. It's incredibly important that when we say we do good work, that should not come from us. Someone else should be able to qualify, quantify, and validate that. So I think digital technology in trauma is incredibly helpful because of the timeliness of how trauma care is attributed to different areas.
Thank you so much, sir. So we also have with us Dr. Anshul Chaudhary here from Bill and Melinda Gates Foundation, and you're the program officer there, specifically delving into digital health. Right. So then, sir, what is the value proposition that led you and your organization to prioritize supporting the country's Ayushman Bharat digital mission journey? And maybe if you could help us in identifying some of the challenges that need to be solved.
Thank you for that question. When you consider ABDM per se and how its journey started, we also need to reflect back on the healthcare ecosystem of the country, how it has evolved, as well as how digital applications have evolved. So if you consider back in 2016 or 17 also, we did let's say, primarily we support areas, like we have defined areas of support to the various programs that we cater to. But at the same time, when we dwelled into a particular problem as to how we can actually make it more meaningful, we went into a deep dive journey wherein we discovered that across the country we have approximately 10 lakh healthcare facilities of various sizes, right from tertiary hospital like AIIMS to right down to the sub-centers and all, and even the pharmacies for that matter. If all this data needs to talk to each other, then if you consider the landscape of even the digital health applications available in the country, it's more than 20,000. And that's a huge number. And to make them interact, if it's on a one-to-one basis, it will be more millions of API interactions or integrations will need to happen. So it's practically not exactly the best way to do things altogether. So back then, so we also realized there are other problems, like there were lack of unique identifiers. So whether it's on the unique identifiers, I mean, like for example, we have ABHA today, the Ayushman Bharat Health Account number, or we have registries for the health facilities and the healthcare professionals in the country. These were non-existent back in 2016. Or at least, even if they were there, they were working in silos. So when you consider all these things, the siloed data structures that exist across the country, how do you make them talk to each other? So the interoperability required to be built up. And that is where I think the ABDM program, the Ayushman Bharat Digital Mission, has played a pivotal role in at least laying down the foundation for this entire journey altogether. Now, there was a very particular question in the audience also, like, there are two aims, how do they talk to each other? So that is where ABDM comes into play, whether it's the e-hospital application that is deployed over there, or e-social, for that matter. To make them talk, the ABDM brings in a layer in between, and that is how it helps out. And there were some very good presentations in the morning, the startup pitches, and yeah, there were some very good presentations in the morning in the, let's say, startup pitches and all, which are solving for some of these issues also. And as Professor Mishra rightly pointed out, one of the challenges that we are facing right now is awareness. So he mentioned it as ignorance, but I will take it as awareness, because frankly, all these interventions, etc., coming into the market, but to take it to doctors and to healthcare professionals, that awareness needs to be built in, the adoption takes a little while, and that is where startups can play a major role altogether. Like, for example, digitization of prescriptions. If the handwriting can be analyzed altogether and it can be made available in a seamless manner, that is important, because frankly, the patient to the doctor interaction should not really be impaired by technology, rather it should be enabled. So I think those are certain areas which can work upon. There are many more, I think, use cases that need to be solved for, and areas that need to be worked on, but these are some of the things that come to my mind right now.
Right. So, Dr. Chaudhary, I just have a follow-up question on this. So, while you talk about interoperability, then how do you think institutes of national importance like IITs and aims, they can then contribute to the digital health journey of the country together?
Okay. So, when you talk about aims, interestingly, aims has been at the forefront of, let's say, ABDM for that matter. Like, I remember sitting back in one of the meeting rooms within aims, in this premises only, when we were onboarding them into the national, like the Ayushman Bharat Digital Mission, the health facility registry, the healthcare professionals registry for that matter. And at that point of time, we realized that, okay, there was, and they were very receptive for that matter. And there are certain applications that have been adopted across various institutes. For example, the scan and share use case, which is decreasing the queues that form even in the OPDs or even in the lineups, reducing the time from, let's say, getting an appointment from, let's say, an hour to a few minutes altogether. That is a huge change. Now, when any technology gets developed, and where IITs do come into play, because they can, like, whether it's an incubation center or any applications that are coming directly out from there, and its implementation within institutes, which institutes like aims can actually help roll out. That is where I think the intersection happens, and this is pivotal or, let's say, important in taking it forward. So when you have examples of institutes like aims actually implementing these applications, and how and the success stories that come out, that actually translates into the momentum getting built up and being adopted across the country. Because anything that happens, we look up to aims for that. In fact, one of the, I was reading upon one of the articles of Professor Srinivas for that matter, and he mentioned that they primarily want people to be referred here for tertiary care only, and not for the primary care things as such. So I think this was in December. But that's a very good use case wherein can we solve for all these issues right at, let's say, the PHC, the sub-centers and the other levels, and then only certain patients who need to be referred altogether are referred via these digital pathways to aims for that matter.
Thank you so much, Dr. Chaudhary. And on a very parallel line, I would like to then move on to Himanshu here from National Health Authority. So, how do you think, because we were talking about Ayushman Bharat Digital Mission, right? And our Technology Innovation Hub, Drishti cps, which comes under the National Mission of Interdisciplinary Cyber Physical Systems. We work a lot with artificial intelligence, simulation, modeling, visualization, right? So how do you think ABDM can support the use of these emerging tools or technologies in the healthcare domain?
Thank you for the question, and really interesting question as well, right? And again, I got so many things or so many examples that I can quote from the discussion that started from morning itself to maybe answer this, right? So there were, for instance, presentations that have happened where questions were raised, can the technology that you have built can be utilized in another specialty altogether? And the answer to that was, yes, just the data is needed and then it's just a click of a button. Similarly, for any other, for instance, digitization of prescriptions as well, once you have the data, and it should be high quality data that's present, because in cases where we are working on emerging technologies, when we are working on artificial intelligence as well, we always talk about this bit that it's GIGO as well, garbage in, garbage out. So data quality is something that matters quite a lot. So through ABDM, what has been made possible is obviously create that mechanism, create that backbone where obviously data which is getting captured at multiple levels can be made available at different levels. So that's where interoperability was also talked about. And so ABDM in a way is setting that standard out there so as to ensure that the data quality data is available, so as to ensure that there are technologies that can be built upon it. And for that matter, I think all the institutions that are there, so for instance, I'll just take an example. While, for instance, we are not working with IIT, we have not started working with IIT Indore, but there is quite a center of digital health that's already there in IIT Bombay, and National Health Authority is working with quite a center of digital health to ensure that whatever is happening in the academic domain, in the research domain, can then be adopted as well, and there is then adoption in industry as well for the same. And AIIMS, again, as Anshul also mentioned, has played a pivotal role for any of the use cases that we have developed or solutions that have been developed over and above the data that we have received. They have been tried out, or they have been showcased, actually, I will not even say tried out, but showcased in, for instance, institutions like AIIMS. So for instance, scan and share is what Anshul talked about, right? If we would have gone to a particular hospital in let's say maybe 5 years back, 7 years back, on the OPD counter you would have to maybe fill a form where you are providing all your details and so on and so forth. And if I am not a literate individual, I might not be able to write those details. So I'm just saying my name, and my name gets recorded, some spelling get recorded here, and in other institution it gets recorded in some other way. There is no interoperability. The data quality also suffers quite a lot. But through scan and share, what we have been able to do is to be able to, just by scanning a QR code, share the right details of the patient, which is the first thing in itself, right? Details of the patient with the OPD counter, so that that mistake is not made. And then everything else that's there, all the electronic health records that are generated over and above them that are linked to that individual's unique health ID. So I think we have been discussing that there are the possibilities of data science contributing to the healthcare space are numerous. And I think what ABDM is trying to provide is that backbone where you're able to access that data, you are able to improve the quality of data, and then this is interoperable as well. Just imagine the 10 odd presentations that we saw in the morning. If all those systems were already talking to each other, what impact, as in it would have been 100-folds the impact that we would be able to see actually on ground once they're talking to each other.
At our TIH and with Dr. Agarwal as well, we have been able to work on a digital twin platform. We have been able to delve into the digital twin technology, especially in healthcare. So how do you think we can align the work that we are doing? And we have also, we are demonstrating the platform here. So how do you think we can align ourselves better with NHA's mission?
Absolutely. Again, so, okay, maybe I'll take this question and maybe tweak it a little bit. Align with NHA is something that's not required. Actually, again, NHA is a facilitator. Through Ayushman Bharat Digital Mission, we are facilitating the interoperability or ensuring that there are data standards that are established which would lead to interoperability. So when you talk about digital twin technology, and again, disclaimer that I'm not an expert at all, right? Whatever I read about digital twin technology was maybe somewhere here and there earlier, and then maybe last couple of days I was reading about it, and specifically how it is utilized in healthcare, right? So for digital twin in healthcare as well, I think one of the steps is obviously having that model preparation, right? And for model preparation, for having a virtual model as well, you need a lot of data, right? If there is interoperability between the systems, so I'll take an example. Last month, I was having some issues, gastric issues, right? So I went to a general practitioner. He recommended some medication and asked me to get some tests done. And in one day, I visited 3 different facilities to get 3 different types of tests done. I went to a path lab to get my blood tested. I went to an imaging lab to get an ultrasound, and then I went to another diagnostic lab to get actually an ECG done. If all this data, for you to be able to work on digital twin, you want all this data uploaded in a particular format, in a particular standard.
Seamlessly integrated maybe. And
it needs to be integrated and it needs to be there, right? If all this is standardized and you're able to kind of put all this data in a standardized format to develop that model, then obviously digital twin will work in a much more better fashion. So that's something that's getting enabled here.
Yes, sir.
Pardon my ignorance, so I'm still very new to the Indian system, so to speak. So if you look at the EHR, the penetration of Epic, which is the largest EHR provider in America, is substantial. Still in the state of Michigan, where I practice, there are 34 hospitals and 6 EHRs. And it is sometimes impossible to get a CAT scan into our system, in the Epic system, which is the largest system. So this is a question I have, which is similar to what Dr. Mishra had raised. We are very new in EHR. The penetration of EHR is very suboptimal, to say the least, in this country, which is so digitally advanced. Can't the government develop a mandate to say, these are the only EHRs that you guys will use? Is it a very naive question? Because this is the time to do it. Once all the commercial players are in, it will be really hard for you to change the equation.
Thank you. Yeah, thank you so much for the question. And this is really great, right? And I think absolutely, government maybe can do this as well, that these are the set of EHR systems that you should use, right? But that's the beauty of Ayushman Bharat Digital Mission. What it allows is, it doesn't constrain your options actually. What it is trying to do is, it is allowing all the private providers to integrate their system with the ABDM ecosystem. There are already more than 160 players who have integrated their systems, and there are a couple of players who are here as well, who have integrated their systems so as to ensure that the doctor doesn't need to, for me as an individual doctor, maybe a particular system, I've already been using it, or it makes more sense than any other software that's out there. So I should not be constrained, and option is the approach that currently government is trying to take. While at the same time, obviously there are systems that are there, government is also trying to work on this, that there should be standard systems that are already there, which can be easily adopted for someone who already is not using the system. But at the same time, if someone is already using the system, if there is a system that's getting utilized in, let's say, Maxes or Apollos in India, then we are not asking them to switch to another system, that these are only the 6 EHR systems that you are using. What we are trying to say is that you should integrate your system in the ABDM ecosystem, so that your system can also already talk to the 160 other systems that are there. And there are 1,000 plus in line, which are already there.
Right. Just to add to this, so I think the approach that has been taken has been rather a mandatory approach. It is more about enablement. So if you think of as you rightly mentioned, EHR penetration is like pretty low altogether. there are programs that the national authority is running and they are in the public domain. So one is of course incentivizing all these application players. One is called the Digital Health Incentive Scheme. So whether it's the facilities or these application providers, incentivizing them, that is one thing. And also there is something called system integrators that are coming into play, because when you consider the tier 2 and tier 3 cities, the penetration over there is pretty low. So how to bring them into the, connect them to the national entire ecosystem or the health stack altogether. So that is where the programs are already running by the government. And I think it is more about enabling them and taking an organic approach, let's put it that way, rather than having a counterproductive thing altogether.
Right, right. Absolutely. So as we talk about the huge amount of data that is generated when we talk about the healthcare sector, so sir, then I would like to understand from you, because of your then immersive experience in the genomic side of the aspects, the genomic studies, what role do digital biomarkers play in monitoring diseases, and especially at the molecular level? And how can this information be translated into effective healthcare strategies?
Yeah, so thank you for the question. So now coming from a research institute, our perspective is a bit different than being from a clinical institute. So when we talk of digital biomarkers and say data like genomics and other things, so these have been usually, and these are governed by more stringent laws. Right. The research level data, genomics data especially. And you need to have a very well-built pipeline for the, apart from the ethical part, from the consent side of the participant and patient. And these have been usually, because of these constraints, have been kept in silos in the institutions which used to generate these data. Right. Now, like with time and with the interventions from DBT, then NIHA and other authorities also, they have now been formulating that all the data which is generated in perspective of these biomarkers or genomics, proteomics, etc., would be kept on a central repositories. And those, like we have just now got the mandate that RCB Faridabad will be hosting all the genomics data, and it will be accessible in an anonymized manner and as per the declaration of the confirmation tool.
Selection of databases in the setting is important. That is what you are trying to highlight. Right?
So more than the databases, also keep in thing that, see, genomics data or these data have a huge potential, because see, genomics is now rising, and 10 years down the lane, you may have diseases which you don't know now will be, you could actually figure out 10 years down the lane. The genomics data you release into the public domain, and it becomes haywire for the participant that he was already having that particular mutation or digital biomarker which he was not made aware of now, but later on somebody else will make him aware of that thing, which is a major detrimental in hosting that data. So you need to be very careful with hosting of genomic data, and specifically which has identifying capabilities. So genomics data has to be held in a very different way than the clinical metadata. And I think now authorities, NIHA and others, and they have also started looking at that perspective, that how to actually look at the genomics and other these data.
Thank you so much, sir. So we can have two quick questions from the audience, keeping the time crunch in mind. Yes.
This question is to Himanshu. 80%, we were talking about 80% of healthcare is private. There are a lot of non-MBBS healthcare providers in India. So I understand that ABDM is using HL7 FHIR for data standards, right? So what is the plan to ensure that we have our own data standards, like how we have Bharat data standard for engines? Can we have a healthcare specific data standards which will take care of indigenous, healthcare services in India, apart from, evidence-based or Western type of health standards?
Sorry, can you repeat the last part once again? There was some noise.
My question is, are we planning, or will we see a particular healthcare data standard exchange format from India, for the Indian healthcare medical system, which is far more complex than the Western?
Okay. Nice, thank you for the question. And again, I think something that you have already mentioned, that we are already utilizing the FIRE standards, right? So that's the basis that we have utilized for building whatever we are talking about in terms of integration. In terms of whether we'll be having our own standards, I think again, it's a journey that we'll need to take up. I don't have again, I'll be very candid about it, I don't have an immediate answer that is it going to happen and when is it going to happen. But yes, I do understand that Indian health system, ecosystem in itself has its own complexities, which are far different from what's there in the Western countries, right? And when we go through something like this, let's say changing the health standards as well, or having our own health standards, it will take a lot of time. I can take maybe one small example, and it's maybe taken apart from NHA and what National Health Authority is doing, and maybe from what I've seen in the past as well. So I've worked in, for instance, nutrition program as well. And I know that for now, for instance, when we categorize a patient as anemic, we are following certain standards that are there, that okay, your hemoglobin level should be less than a particular, let's say, a particular value, right? Even those values are something, there are research papers that have been written that those values that we are currently utilizing in Indian systems may not be valid for Indian patients, right? We need to come up with new standards altogether to even identify something as simple as, let's say, an anemic patient. So yes, I definitely understand that there is a need for this, but what exactly would be the plan, and how exactly are we going to do this is something that I am currently not aware of, and I'll definitely try to find it out and maybe answer it in a better manner as well. But if anyone else on the panel or anyone in the audience has maybe some more clarity, they please feel free to add that.
नहीं, क्लैरिटी तो आपको ही देनी पड़ेगी, ऑडियंस में कोई नहीं देगा. Since you are working for Ayushman Bharat, in India we do not have a figure for any disease, credible figure. Whatever we have out of small studies. Okay, so I don't know how many laparoscopic cholecystectomies are performed all across India every year. Like US, they have this 500,000 figure is there for cholecystectomy, 700,000 for hernia repairs. So when we can have that through this ABDM, whatever you are saying, and integrating both public and private hospitals, and when we are going to standardize at least minimum data set, if I want to know what is the infection rate of aims, cardiac surgery or hernia surgery or gallbladder surgery or ICU mortality, like that. So is it possible through this system what you are trying to develop, and how soon it can be done? And you may not have answer right now, but I think you can give the feedback to the National Health Authority. That is what we need. What is our average hospital stay? Why patients are staying longer in public hospitals, shorter in corporate hospital? What's happening? Because US it was easy, because even in public hospitals, this data was coming through billing. In India, in public sector, we are not charging anything, so the billing is not an issue. But corporate you have. So at least let's develop something where we can have those figures, and this will help in raising the quality of healthcare objectively.
If I may add to that, I might disagree with you that if you leave people to do their own thing, it's not going to happen. Even in the US, there was so you cannot admit a patient and not have that information registered. So when we do health services research, we have Medicare, Medicaid databases which have 250 million, 300 million data points. Why did that happen? Do you think we as physicians are really interested in sitting at my chart? At Michigan, we call it my chart. Everybody hates my chart, but it's not an option. So I tend to agree with Dr. Mishra in the sense, maybe we shouldn't be giving this option. So I'm not asking us to rule like an authoritative military rule, but certain rules.
Yeah, certain things have to be mandatory.
I absolutely agree to that. And
Because you,
so,
I think you would know better that how difficult it is to bring a change
yes,
in any system. I refuse to change, but if it is mandatory, I will change. Like in my small hospital now, they have put up a new HIS. So I have to follow that. I have no option now.
absolutely.
I have to follow that.
Sir, so, okay, couple of things. I think, first of all, your question is really valid, right? It's not just the number of particular procedures that have been conducted and the data related to that that we don't know at a collective level. I think in India, at present, we don't even have the correct data about number of healthcare professionals who are out there. Right? So that's what we are enabling. We are not just enabling, or we are not just working on a specific problem saying that, okay, we'll mandate this and this is how it's going to happen. Obviously, there are two ways to go about it. One is obviously you mandate something, and that's how it happens, as in everyone needs to register on healthcare professional registry that's out there. And once you have the HPID, then you can proceed further. Everyone needs to use a system that's ABDM enabled, and that's how you go about it. So that's one way to look at things, and that definitely is something that's getting explored as well. So for instance, in government hospitals, e-Sushrut, e-hospital systems are getting utilized. Right? Now, as a top-down approach, these systems have also been made ABDM enabled so as to ensure that we are getting the data. Now, first step has been taken. These are now ABDM enabled. Now the next step needs to be taken, where this can be made mandatory, that electronic health records are generated and linked as well. So it's a step-by-step process that's there, but at the same time, for private sector specifically, again, we need to look at what is the model that would work best, and we are in initial stages of recognizing that. So what, for instance, National Health Authority has now done is, they have started this 100 microsites initiative, where what we are doing is we are picking 100 small geographies as well. And what we are doing is, we are sending across individuals who are going from door to door of doctors, of small clinics, small hospitals, and making them aware about ABDM, making them aware about HMISs, ABDM enabled HMISs that are there, so as to ensure that they adopt it and generate records that follow that minimum standard of health record that's there, so as to make it interoperable and usable maybe later at an aggregated level. So that's exactly what's enabling. I don't think that there is a disagreement here. I completely agree with you, that's what required, and we are taking initiative towards it. And it will maybe take time to understand where would the mandatory part work and where would the voluntary part work. We are hopeful that the voluntary part also work, as it has done in India's digital or e-payment journey as well.
I think इसको हिमांशु अगर आप NABH को लगा दें इसमें, उनके जो मैंडेशन है, जो उनके टिक बॉक्स, जो hospitals have to tick boxes, put this also as a condition there, because NABH now most private hospitals want to get NABH approved. Even government, there is initiatives now, like aims also, they have got the laboratory accredited and are working on various burn center, trauma center separately. So trauma center is NABH accredited. So I think at least you have that minimum data set and standards basically. What NABH also does is the processes. They see at the process, but they have made this, these are the for hospital safety, patient safety, and what are the processes. So if you put it through NABH, at least those hospitals, small or big, which need NABH recognition, will at least comply with that.
Yeah. Already underway, and maybe we'll discuss more about it offline.
Yeah, so one thing which I can share about, and Dr. Mishra's and Dr. Sridhar Rao's feedback. So like recently in the past, I was in Taiwan for 15 days and they have this TVGH. So it's a very interesting story. So TVGH is, it claims to be one of, that is Taichung Veterans General Hospital. It claims, and it is actually, we went there, so one of the smartest hospitals in the world. And they were referring to Hopkins and maybe some in Michigan also. So what they do is, see, what they understand, and we should understand rather better, is the end user is more tech savvy. He is ready to accept everything. It is we who need to implement and change. Second thing is, they enabled, we have aims Rishikesh, we have aims, aims Jammu is here. So all the aims and Bilaspur, Jodhpur, they enabled their peripheral centers first. They enabled the digital adoption, digital technology to their telemedicine units, remote units, and they aggregated, made it compulsory, and they became the smartest institute. So that is, and for your answer also, they crowdsourced and later on developed Taiwan's own digital operability and interchange of data framework, guidelines, and standards. So this we could see there in 10 days, that how they have implemented, and they have a very bad geographical regime where the remote units are really remote. So we do have similar situations.
I'm very hopeful India will reach there. As an example, the other day I went to buy bananas and I wanted to give him cash and he said, "Sir, Paytm nahi hai." Exactly. So if that vendor has the digital capability, why not other people? And the other thing that Dr. Mishra had briefly talked about, in the US, why do you think this is happening? It's completely linked to billing. Have money, will talk. So if I submit a payment for a laparoscopic cholecystectomy, I can't just say I did a lap chole. There have to be op note, there have to be indications, history and physicals. There are 7 aspects of history that have to be covered. It's clearly linked to money. It's clearly linked to billing, coding. So that's why we call it billing, coding, and documentation. And so if you make for the private hospitals that your initiative, if you are billing for this, you have to have certain degree of documentation to support this, it will happen. I'm sorry to put you on the spot.
Yes, thank you so much for sharing your inputs here today. So I would just like to request Dr. Agarwal here to hand over a token of gratitude to our experts here.
We already have one, so give it to the people who don't.
So I request everybody to please proceed for a technology demonstration walkthrough. We have around 22, 23 stalls here, and then we proceed for lunch. Yeah, so thank you everybody. Yeah. We all resume in next 45 minutes for the roundtable discussion.
He has an appointment with Mr. Modi. After the session, we will go.
Resistance is always there.
The resistance will always be there. Because when we used to go, when we got this NDHM and we got rolled up to ABD, the resistance that comes from state level and everything else, it's a challenge. And even, I'll be honest, even when we got teams really on board, it was almost 3 meetings, including one board meeting over here, just to convince people to register. I was building up the registry that time. I know what challenges
It takes time. I think if you push a date,
But at least we should have this robust discussion. Like what he was talking about Taiwan, they have more data than the population because they have data on all the people who died. Generational data. Like if you want to, like you were saying last Friday, right? Want to see the incident. It's accessible. All my colleagues of mine who work in China for that reason. So we have a lot of data. some of the Scandinavian countries, why do you think all these landmarks and
Because they have 11-year follow-up.
Correct.
20-year follow-up.
I'm good. How are you? In fact, this fire bundle that was being said, CDAC is actually looking on that. So CDAC is
He's very environmentally conscious. So, every time I come to India, I see the potential. Then I see next time I come, so much potential. The thing is like that Kela wala told me, sir, आपके पास Paytm नहीं है. I felt like a idiot. Oh my God, I don't know Paytm. We know that India is providing engineering, brain engineering capital. We know that India is the road traffic accident capital. These are not good designations to bother the Indian ambassador to the US at a roundtable session of 20 people. Some reason I wanted to we have zero. Deepak has been collecting data. That's the only data. We are trying to organize the data that communicates with each other. Other ordinary institutes, we don't have. Yeah, because it is in silos, right? Correct. But he is willing to share it. There is no funding for it. I am trying to get rich alumni from University of Michigan who are CEOs of whatever companies to give us some money so that we can have a database of neurotrauma registry for India. I have gone to philanthropic people, asked them, can you give me some money for this? It's really hard to go to the US unless I get to meet Sundar Pichai or some dude say, hey, can you help? Maybe, but I don't have that audience to get to. So, same way he was talking about omics data and all that. So much potential. Every time I come here, and I used to run research methods courses at ordinary.
No.
I was maybe this one.
No, this fine. Lunch is ready. Please proceed for lunch. Everyone, lunch. We will join back exactly at 2 p.m. So please have your lunch early.
Why suddenly Indians are going to behave differently from some other populations? Show me the hypothesis. Where is the hypothesis? Don't show me studies that we want to replicate. Where is the hypothesis? You should work on your debate. You should perhaps, we should say, hey, we want to replicate that study from India. Maybe it is not. But that's not law. The general idea कि उसको move on कर रहे हैं, that guy who was talking about, I'm going to use this magnesium. Okay, fine. Where is the novelty? Why can't you develop it? Unless you give them, they should develop it. I used to, and Dr. Mishra used to say, go सबको बोलो research करने. And I used to be harsh. I say, ordinary institutes, the IITs of the world, don't do research. And people didn't like me, but it doesn't matter. I give a talk and come back to the US. But we have to create that. We have to create that environment. It should be all the
A very good afternoon, everyone. So as we resume our session post-lunch, we had a plan for the roundtable discussion, but before that, we would like to hear the remaining startup pitches. We had a couple of them in the first half. We would have the rest now, and then we will start with our roundtable discussions. I can already see the experts are there, or they are already sitting together. So I think let us start with the startup pitch, and then we can resume our discussions further. So I would like to first invite Sahil from Primary Health Tech Private Limited. He's the founder, and the flagship product MobiLab, that is what he is going to present and talk about.
Hello, good afternoon. Atay, can I start? Yeah, okay. So hi, I am Sahil from Primary Health Tech Private Limited, and we have developed a MobiLab device, which is a portable device which is developed for point of care testing for kidney, liver, pancreas and heart. So total 25 parameters can be detected by using this device. This is a digital device, so everything goes in the cloud. And we have done more than 50,000 patient samples across 5 different hospitals across India, and we have deployed 50 devices in the market to actually just see how the customer reaction is there. Our major target is that to solve the problem for a primary care. So we have a customer who first goes to the doctor, and the doctor prescribes LFT, KFT, CBC and other parameters. So we want to solve all these parameters with this device. And in future we think that with the teleconsultation coming, e-pharmacy coming, all these things can be integrated. So in each rural area, in each villages, we will be having a setup where a device of the size of this particular device will be placed in each of these pharmacy, and then you can do entire healthcare delivery at rural India, and these type of place which are remote areas, you can have these facilities, so people do not have to travel to big cities for these particular things. So happy to answer any of your questions. Yeah.
What about your validation of these tests?
So what we did, we have done different phases of validation. So our startup is based out of IIT Guwahati. So we did validation in Guwahati Medical College, GNRC and Name Care Hospital. And we are doing currently validation in AIIMS New Delhi as well, and collaborating with different other hospitals to prove the efficacy of the device. How we are doing the validation? We are taking the auto analyzers of Siemens and J&J Victros machine and comparing our results, and we have found out the correlation to be 92 to 94% with each different test. So cholesterol has 93% and then hemoglobin has 95% correlation with the auto analyzer.
Those are exceptionally good results, first
Yes,
of
sir.
all.
Yeah.
The concept and idea is brilliant.
Yeah.
It's also a major felt need for our country that you should have devices like this.
Yeah.
What is the technology behind this? Is it
Spectrophotometry.
It is spectrophotometry.
Yeah, so same which
So
is used.
microfluidics and spectrophotometry.
So microfluidics we will be coming in the second phase. Right now there is a cartridge like this. So one cartridge for one test like a glucometer that has to be put in the device, and then you get the reading. We are also working with IIT Guwahati to develop a microfluidics platform, but that will require another 2 years of time to actually validate. So we are having a prototype, but then the validation will require some time.
So there are devices like, of course, Theranos is a spectacular failure for something like this.
Yeah.
But having said that, the Chinese do have a microfluidic technology available where they use, I think they are able to do more than one test at a time. You are doing one test at a time?
One test at a time, then.
So if you have to do 10 tests, you have to use 10 cartridges.
Yeah.
What is the cost of that?
So right now we are selling at around 40 to 50 rupees per cartridge, but the manufacturing cost is 10 to 12 rupees. That can again go down to 4 to 5 rupees in future. Yeah. Yep. Thank you. Any other question? Thank you so much.
Thank you so much, Sahil. Moving on, we have our next team from Sinnersense.
So, good afternoon all. I'm Gunjan here, co-founder of Sinnersense. We have developed the motion sensor-based technology for people with locomotion disability or in sports or orthopedic disorder. So we are able to measure the joint range of motion of the lower body, where we can track how the deviation in a walking or in a running, and accordingly the therapy will be provided and how fast recovery is coming back. We can monitor it, we can also diagnostic at somewhat level, very early stage, and what kind of specialized custom-based therapy to be provided for the patient. So that's what we are able to do, and this is wearable, portable, we can do any setting. It's kind of a small laptop back setting where we do not require a 1.5 crore rupees setup of the gate lab installation within the hospital clinical setting. So we have developed the very sensor-based technology is very, very small and portable. So that's what we do. And we are looking forward to collaboration with institutes like aiims and other setups. So maybe we can collaborate together and how we can roll out at a very affordable cost to the end user, and also at a national level institutes like the aiims or similar institute in the government settings. So we can reach out to more people at who actually need this kind of solution. Yeah. So thank you so much. So we put at a different joint for one per year, okay? One per year and one per year for a lower body. And the three different joints bilaterally we can put it, and we can ask patient to walk for 2 steps, okay? And then we get the data wirelessly, okay? So there is no fixed setup required for camera like this, okay? And we get the same accuracy level data what we have validated with like different traditional gate lab in India. So 98% accuracy we got from this technology to compare to traditional gate lab data. And we can do for sport up to like 13-14 kilometers per hour walking, running. We can do on a treadmill data analysis for them also in sports. So for a therapy, we can at the individual joint level, for a gait analysis that we are providing at each joint kinematic information. So range of motion we are providing, lateral, AP and the international rotation movement of the joint, hip, knee, ankle and pelvic. And also we provide spatiotemporal parameters like single support, double support, speed, cadence, and stride time, stride length. That kind of information we are also providing from the same set of the data. So you have a wearable device and one software. Yes. Yes, 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 yes. Both hardware and software together.
So how it is going to shorten the, like, is it doctor, is it clinician, we are going to do by just our visual assessment or by clinical examination? How this is going to make a difference in that?
So it's a good question, because visually most of the doctor in clinic isn't doing visual, but you have subjective analysis. Maybe you do and some other in the same setting, maybe you have a different opinion of it from the same patient. Here we do not have like a subjective, we have objective data information. So that information we can interpret from the same patient, from the same setting, different doctor can be same interpretation compared to subjective analysis. Thank you.
Thank you so much. Next we have Dr. Vishesh and Dr. Divya with us from Mediseva. Medivision, I'm sorry. Yeah.
Hi, very good afternoon everyone. I'm Dr. Vishesh Kasliwal and she's Dr. Divya Vakaria. We are team Medivision. So what we know is that when you go to an ophthalmologist, everybody would have seen there's a big machine where you have to put up your chin and the doctor visualizes. So it is known as a slit lamp. But it is, one, it is very expensive and it is not portable. So what solution we brought in was to have a portable slit lamp which could be used like for mass screening for each and every patient, and so that is what we have created. We are even building an AI text solution for it, where the device will be, it is a mobile friendly device basically. So the mobile would be clicking multiple images and through it the actual images would be coming out, and my technology, my AI would be sensing it and giving up the solution that what is the exact problem onto it. So this is what we have built. Thank you so much. So we are open for any questions.
So has any field trial has been done?
Yes, sir.
Any field trial has been done to test this machine, how accurate it is?
I have actually tested in my patients. Okay. We have collected data of around 6,000 eyes, which means 3,000 patients have been examined with it. Yeah.
Thank you so much, sir. Thanks.
Thank you so much, Divya and Vishesh. Moving on, we have Dr. Ragesh and his team from IIT Kottayam.
Shall I say? Good afternoon all. So we are here to introduce our product ENOS. So basically this product is used for quality analysis of Ayurvedic products. So we designed this in collaboration with Ayurvedic giant Vaidyaratnam. So using this particular product we'll be able to analyze the quality of the Ayurvedic products. So whether it's good or bad. So at present they are doing it manually by smelling. So instead of that we will be automating this entire process using our ENOS. So our USP is we have a 3-second response time, and we have integrated 16 sensors on a same panel, and we are analyzing the result using the 16 sensors. So the accuracy level is about 97.9%. So this is our USP. In addition to that, we have certain IP components also. So we have 2 IP components. One is the sensor bed arrangement, and second one comes with the filter segments, I mean hardware and software filter segments. These are some of the IP components available. And we have nearly tested with 10,000 samples, and the accuracy is as I mentioned. Thank you.
How do you make a solid into a vapor for it to be? I'm presuming somewhere there has to be some vaporization of this product, right?
Yeah.
So how do you do that?
Basically, we are precisely doing this for lay hymns. So lay hymns, semi-solid, semi-solid. Yeah, they will emit gases actually.
So they
automatically emit gases, and we are predicting the quality.
What stage of product development are you at?
So we are in the, POC stage, proof of concept.
Okay, so how many POCs you've done so far?
We have just now created one POC, and we have tested it nearly 10,000 samples.
And what's the accuracy?
Yeah, 97.9%, more than 97.9.
Do you have data whether there are people, I'm presuming there are people who come up with an impure product. What's the extent of the problem you're trying to solve here?
Actually, at present it's prone to human errors. They are smelling it, right? So if there is any issue with his nose or something, if he's having a cold or something, the result will be negative. But when you are standardizing it like this, the quality will be, we can assure the quality.
Knowing it's like in Ayurveda there is no benchmark system nowadays. It is purely depending upon the experience of the evaluator. So now we are just automating it.
Why are you just limited to the Ayurvedic product? You can go to the forensic science, you can go to those drug detection at airports. There are so many other.
Actually, this is as
in the air. So many things can be
yeah.
you can analyze.
So the major problem.
Widen your field of things rather than getting limited to
The major problem is with the availability of sensors. Actually, sensors are not available in the market. So what we did is we integrated 16 different sensors available in the market, and we have created our own sensor for this particular application. For forensic science, we will have to repeat this thing and to create another sensor bed. So it's a time-consuming process. We took nearly 1 year for setting up this particular sensor bed.
Why you chose Ayurvedic for Ayurvedic?
So because we have a collaborator, and it was their requirement. The Ayurvedic part actually. Yeah, that's it.
Are you able to adapt the same sensor for something like pollution?
Yeah, definitely. Yeah, it can be.
And is it a low-cost sensor?
The sensors are low cost, but as I mentioned, the assembly process is a bit costly because we are printing 4-layer PCB, and some embedding mechanisms are also there. So it's all about wafer connectivity, so it's a bit costly process. But once it is manufactured, then you can bulk manufacture it in under 1,000 rupees per sensor. Yeah, grading is possible. Thank you, sir. Thank you.
Thank you so much, Dr. Ragesh. Next, we have a team from NEOS. NEOS, right? Okay, your flagship product is NEOS? Okay, perfect. Both of you are together, give a presentation.
He's not from NEOS, I'm from NEOS.
Okay, who's going first? Perfect.
Hello, everybody. My name is Avnish Parekh. I'm the CEO and co-founder of a startup called NEOS Healthtech. NEOS Healthtech is building a product called Flow, and we're building Flow with the intention to remove the work from the workflow. And Flow is basically a web-based application where we've taken all the tools required by a radiologist to the cloud. And on top of this, we have added layers of artificial intelligence. So today we have about 15 different artificial intelligence algorithms which work in tandem to look at different modalities, let's say CTs, X-rays, MRIs, and we give a preliminary report to the radiologist. So we detect, we quantify, and then we take all that information and put it in an editable format for the radiologist to give to the clinician or to the patients. Yes, sir.
There are many such products.
Definitely.
There are many such products in the US. There are really, really good products that look at X-rays and digitally analyze. What's different from your technology that's different from what is available in the market?
Definitely. So what we have done is we've recreated the entire workflow. So today we do not ask the radiologist to move away from what they are used to, what they're comfortable with, and we have an entire plethora of different AI algorithms. So not just for X-ray chest or X-ray MSK, we do MRI brain also, we do MRI spine also. So a hospital or any site can just have a plug-and-play solution, and they'll have access to all kinds of different artificial intelligence algorithms. So to give an example which is very prevalent in the US is Blackford AI, where they have created this amalgamation of different AI algorithms. So we've done something similar but made it useful in an Indian context.
So when you say plug and play, what is the implementation like?
So we need to have a local interface at their machines. We take it to the cloud, and then it's just a profile creation from that point on.
What's the setup time?
About 30-35 minutes per center. That's it. If they have any specific requirements, if they want to add some sort of features, then that's a different discussion. But normally, we've built out our platform keeping everything in mind. Today we go with the pay-per-scan model to reduce the friction with any site that we work with. So if they use 10 scans for artificial intelligence, we're going to charge them for 10. If they use 3, then 3. And we also have a workflow, which is very interesting. And we triage scans, so that can also be an initial buy for the scan center, and then they move on to using different AI algorithms that we have. Right, so we have multiple different algorithms. Some of them have been third-party algorithms as well, and we've trained all of them on an average of at least 3 lakh scans, and the accuracy is over 97%. Right, so Cure.ai is one of our partners. We have them on our platform as well. So different AI companies have different kinds of outputs, right? So Cure.ai is very useful in its abnormal versus normal. So that portion of it can be used combined with other AI algorithms to give a holistic report to the radiologist. So Cure.ai focuses on certain parts of the body. There are other companies that focus on different parts of the body. We put it all together to make it a solution for a hospital or a scan center. Definitely, we are a assistive diagnostic tool. We are a tool for the radiologist to use. So we give this information, insight back to the radiologist, and the radiologist signs off on the report. Definitely, sir. Even with the triage point where we're able to say normal versus abnormal, the doctors can focus on the abnormal, and the normal can be reviewed later. Emergencies, we are not tried yet. We use it in normal radiology settings. We are running a pilot to understand the AI efficiencies on a business case level, and we'll get back to you as soon as we have the results from that. Okay, thank you so much.
Thank you. Next we have a team of UG students, Pratyush and Deepto with us. They have developed a classification model.
So, welcome everyone. I am Pratyush Dey and I'm final year BTech student from Weltech University, Chennai.
And this is Deepak Talukdar, final year BTech student from same university.
So, we have basically built a AI-based detection system of diabetic retinopathy, which has mainly 3 advantages over the conventional system. That is, it is instant, it is cost effective, and can be used anywhere for the user's convenience.
A user can check his diabetic retinopathy or retinal status from his home only. And
so we have devised an live website which is live on the internet, and we have also built an Android application where the user can also check diabetes. The user can also check for diabetic retinopathy positiveness and the status, where the user simply can upload his or her retinal image into the system, and the system immediately predicts it is diabetic retinopathy positive or negative.
yes. And in conventional system, whatever system is available now, there every patient needs to go to hospitals and minimum 4,000 or 5,000 rupees they need to spend. But in our system, only subscription system is there. If you will take that per month subscription, 50 rupees or 60 rupees. So by one subscription, they can check several times of the retina. Okay. Sorry.
So we have basically trained our AI model with convolutional neural network CNN with original retinal images, fundus images, and finally we have built up an algorithm that can immediately predict the analysis part. So eager to answer any queries.
Yes, sir. So how did you account it for heterogeneity from different fundus cameras and ambient light?
Sir, fundus cameras are the conventional system that has been used. The cost of a fundus camera is around 35 lakhs. But the system, algorithm we are devising is, we can simply change a simple selfie image from a smartphone into a retinal image, and that can be inputted into a system to instantly classify the result.
First of all, image transformation will be happened. Then after that, it will give the output.
No, but camera in the mobile phone is not apt to take the microvasculature of retinopathy.
No, sir, that is the thing I am saying. We have trained the algorithm in such a way that a simple selfie image can be transformed to a retinal image with the AI algorithm that we are developing, and it can be inputted in our system to predict the answer or the result.
And depends on the situation of retina, it will give automatic suggestion that now you need to go doctor, now you need to go this within 10 kilometers, it will suggest some doctors, and whatever requirements needs to do, it will suggest.
So there is a portion in an app where if a patient is found affected with diabetic retinopathy, he will or she will be directly suggested with a radius of 10 kilometers, where the doctors will be present with online booking system, and they can directly be connected with them, so the patient gets an immediate solution to the problem he or she is having.
How do you take this image? Somebody takes a mobile phone camera and puts it near the eye?
No, that is the thing we are developing, sir. The current situation is fundus cameras are required for taking the retinal images, which is costly. User needs to come to the labs, pay almost 500.
Your AI is trained on images taken from fundus camera.
Yes, sir. Yes, sir.
But you haven't yet reached a situation where you can image the retina in the field.
Yes, sir. That is the thing we are developing in the current stage.
In present markets, there is no system which can detect diabetic retinopathy without fundus image. And that is the gap Google has done and Apple has done. But there are also some external devices required, and that is also very costly. And in this gap, we are working to fill this gap that without fundus image, without any external device, so that we can detect the diabetic retinopathy status.
So any queries, sir?
Thank you so much.
Thank you so much, Pratyush and Deepto. Next we have Dr. Amit from IIT Jaipur, and he has developed an intelligent glucose monitoring system.
Okay, good afternoon all of you. So we have developed the intelligent glucometer where you can we have developed the intelligent glucometer where we can measure the blood glucose non-invasively. So you need to just insert your finger. So as a user point of view, it is as good as your pulse oximeter, and through which you can able to measure your blood glucose non-invasively. Apart from that, we are also focusing on controlling of the glucose. So for that, we have developed one mobile app. So where you can scan your food and then it will let you know that after having this particular food item, what will be your predicted blood glucose value. So in that sense, it will help you to control also. So initially this, whatever the prototyping that we have developed it, so at our Jaipur, in the Apex hospital, we have tested it over 300 patient, and we are getting an accuracy of 90% with the serum blood glucose value. So that's all from our side. So we have tested it, and possibly means there is a benchmark, the Clark error grid analysis, through which it has been observed that it is a clinically accurate.
So what's the technology?
Sir, it is optical detection. So basically light is being incident on your fingertip, and at the receiver end there is a detector. The variation in the detector intensity is being observed, and that we are putting in into the AI model, and that actually able to help us to predict the blood glucose value.
And what are you using as your control?
So for the control, what once we are doing it, that means we have developed one app. Okay, so whenever you are eating something, at that time you can take a picture of that. Already there is a database are available.
No, normally whenever you are trying to measure glucose,
Yes.
you have to have some method to measure against. For example, hemoglobin concentration or something has to be there against which
So
you will measure.
that's what, sir, means we have tied with the Apex hospital. Whatever the serum, the patient when it comes to the OPD, so at that time he used to give his sample, blood sample. So at the same time we used to collect the data from that particular patient.
No, that's not what you do. When you are, suppose you are wanting to measure the glucose using the optical measurement.
Yes, sir.
So are you using a laser? What are you using?
So we are using LED.
You are using an
Basically
LED.
is with the
So
specific.
depending on the thickness of the skin or the dirt on the finger or the particular peculiarity of the finger which is inserted, you will get differences in the reading. So to adjust for that, you need an internal control which is within the blood to measure whatever it is that you want to measure, which is what costs. So there are a lot of glucometers available off the shelf which use either resistance or optical or lasers to measure the blood glucose. You can buy it on Amazon also. They don't work because it's not sufficient accuracy.
I do agree, sir, with you that there are in India also there are 2-3 players who are working on it. Okay, we are in the better in that sense that cost effective. So we are just claiming that it is you can use it for a primary healthcare purpose where you can just observe your glycemic profile, and if your glycemic profile is not being for a some period of days, then maybe you can consult a doctor for the further assistance. So it is just to give us some sort of primary indication that your glucose level is increasing or lowering. So that's what we are trying to solve. Not for the accuracy point of view we have focused on, because otherwise with the few sensors we can increase the accuracy, that we have tried it out. But when actually we have done the observation in the Apex hospital, so almost 90% of patients are interested to know that whether their blood glucose value is higher or lower, rather than interested in getting some exact value. So that's what we have observed, and because of that we just thought that there has to be some cost effective solution which can be useful for primary healthcare purpose.
What's the pricing?
So currently means for our prototyping what we have developed, it is around 2,000. We have projected that once it is available in the market, then in the 5,000 it could be available.
So you're saying that's a cheaper price compared to the other devices?
Yes, ma'am.
Are you sure?
Yes, ma'am. Yes, ma'am.
And what are your margins here?
So as I said that, ma'am, means 2,000 is actually our cost, okay, and then we are actually multiplying it around 2.5 times, and that we are projecting to selling in the market.
So you'll sell at a 5,000?
5,000, yes.
Hello.
You need a larger sample size to really validate. 300 is very small.
Yes.
It should be at least 10,000 or something even more to validate.
Yes, sir. We are trying on that, and we are keep on doing our clinical trial at the hospital. Thank you.
Sir, I have one question. I'm audible. So you're using reflectance method?
No, absorb, sir.
Yeah, your absorption method. So basically there will be a light source and there will be a light detector, right?
Yes.
So which factor or which parameter are you considering?
So basically, the light when being incident on your fingertip.
Yeah.
So whatever the sensor that we have chosen, That also we have done it with some sort of judicial study
Okay.
and experimental, through which that sensor is basically hitting the glucose molecule. Okay. So when the light is being incident on your fingertip, at the detector end, definitely there will be a variation according to the blood glucose which is present inside your body.
Okay.
And that variation that we are capturing and that we are putting into the ML model, and then we are able to predict.
But that sensor is available in the market, right? Is it available in the market, or you are manufacturing your own sensor?
That we have used it, that is LED is available, but whatever the post-processing module, that acquisition module, and whatever the ML module that we have developed, that we are considering as
No, sir. I just want to know about the sensor you're using.
sensor is available. Sensor is
I mean, the light source is available.
Light source is available.
The sensor is also available. So basically, to match according to the blood glucose level, there should be some factors considered, right? So you are measuring the intensity of the light, right?
Yes, yes.
Intensity of the reflected light.
Yes.
So how this absorb light. So how this intensity is which relationship you are using? What exactly is the relationship between this variation in intensity and absorption? Or variation in intensity or sensor output? So how you want to relate that?
So basically, for the relation, that calibration point of view that you are talking about.
Yeah.
So whatever the intensity that we are getting it, at the same time, we are getting for that particular person what is the exact blood glucose value. According to that, we are preparing a one regression model, and that actually helps you to predict the.
So, but there will be multiple variations, right? Since heartbeat is there,
Yes.
so blood will be flowing.
Yes.
So it's a kind of noise.
Yes.
In addition to that, the skin tone can vary. For example, black skin, white skin. So how are you going to cancel this noise?
So basically, what we have done it currently, when we have actually done the experiment, at that time we have actually gathered all the parameters for that particular subject. The main fluctuation parameter that we have observed, that is a blood pressure. Okay, with the blood pressure, whatever the variation that we are getting, what are different high blood pressure value person that we have observed, that is highly correlated. So you will require a very large data set to yes, yes, yes. That is the possibility. Yes, yes. It's a very good thought of.
So just to clarify.
We can have the rest of the discussion separately.
Yeah. Okay.
Thank you so much, Dr. Amit. Moving on, we have Dr. Arnav and his team from IIT Mandi.
Hello. So how many of 140 crore Indians use digital options to access healthcare? I believe that's a very, very low number. Why is it? In fact, now picture this, that there's an ABDM-enabled AI guiding you through various healthcare options after thoroughly scanning your medical history upon your consent, and LLM providing a human touch to the conversations. With IoT point of health, with IoT point of care units, such that you are able to get information from ECG, otoscope, and in fact anemia detection on mobile. Well, that's what we are doing. We are trying to create a clubbed picture where the data points are there, and these data points can actually create a proper healthcare profile of a patient, which can then probably be used by hospitals as well as healthcare institutions to provide better and effective healthcare to them. And talking about anemia detection, that's on mobile. The ECG is barely under ₹1,000, which means that you can have a screening, an ECG screening with a device which costs less than ₹1,000. Yeah, that's pretty much it. Open to any questions or queries.
What's your exact deliverable?
Well, currently in this particular project, we are delivering data points from a patient like ECG, otoscope, as well as anemia detection. What we have built is anemia detection on mobile for the first time, and we have a front end as well as a back end ready, where we capture the images on site. Those images are being sent to the back end, the processing happens, and we get a final picture of how the anemia is for the patient, if there is a condition or not.
And this is for the doctors to use?
Doctors to use. In fact, that also acts like a health data point for that particular patient if he goes further down the line to any other doctor.
What do you show the patient? Like if I take that, what do I get?
Whether you are anemic or not? Kind of that, yeah. We have got values for that, like what is the severity level as well.
Again, are you using an infrared sensor to measure the reflectance from
what
the
we are
blood?
doing is, we are capturing images of your conjunctiva, your nails, as well as palm. Now that is being sent to a proper trained model, where we get the inferences, and based on that we detect whether you are anemic or not.
Thank you so much.
Okay. Yeah. Thanks.
Thank you. Next we have startup with us, MSense.
Hello everyone, good afternoon. I am Shiv, co-founder and CEO for MSense. I am joined by Saroj, who heads our business development. So MSense is not directly related to healthcare, so just giving the disclaimer. So we are very much focused in doing the quality inspection in manufacturing. We have two products, digital ears and digital eyes, so which kind of can be correlated with what human eyes can see and do the quality inspection. We are doing that automation. Similarly, what human ears can listen to the sound and do the inspection, we are actually doing the automation for that. So when you talk about ears, you can actually consider like the engine cars are there would be gear assembly. So we listen to those sounds and make sure that the manufactured quality is good. Similarly, visual inspections can vary from whether all the parts are being assembled correctly or not, to any dents, any defects, any printing defects, all those are covered actually. So that's pretty much what we do. We have digital ears, digital eyes. Digital eyes is vision DL and digital ears is acoustic DL.
Can you give us an example?
Okay. Engine assembly. So for example, if you talk about the digital ears, right? So when the engine is manufactured, right? So it goes to the test. These tests run for like 5 to 8 minutes. So normal human being cannot really stand there and listen for 8 minutes to say that, okay, now the engine is good or bad, right? So this was typically not being done. So we are opening up new avenues for doing that actually.
And this is being done on shop floor actually.
Sorry? Okay, so in medical, we are trying out, I'll just tell you because this is totally different, but we are using it for primarily by listening to sound and look at the pulmonary disease detections, and also when it comes to the dialysis part, right? So typically the fistula, if it is not properly done, right? So there is a different sound pattern which was.
The way patient coughs, his pulmonary problems can be detected.
Yes, exactly. Yeah, yeah. That's where we see the application. Thank you. Yeah, thank you.
Thank you so much, Team MSense. Next, we have a team from Healthy Kid.
Good afternoon. Children are our future. Do you know that there are more than 50 million children in India with preventable wellness issues such as malnutrition, obesity, anxiety, depression? What we have done at Traveler Healthy Kid is to have a tech-based health screening in schools. We create a personal health record for the kids that they can use, which has data about their physical wellness, mental wellness, and sports fitness, and that becomes their record for immunization records also. What have we done till now? We have covered more than 100 schools pan-India and covered more than 20,000 kids, identifying these issues. Healthier kids can be looked at by having timely screening, health awareness, and guidance. So we are looking at making sure that the personal health record system leads to predictive analytics and thus leading to a healthier nation. Thank you.
What's the technology you're using now?
So it's basic personal health record system that we are maintaining as a digital record of the kids.
Somebody has to be there to check, take all the parameters and then enter into your system?
Yes, yes. So basically the medical, paramedical staff go to the school and do the screening and they create the personal health record, because currently what happens is NEP 2020 talks about mandatory health screening in schools, but everything is all manual and that gets completely lost, that the data is lost. Okay. Okay, great. So the differentiation is we are using non-invasive devices. We talked about a few of devices about anemia, hemoglobin, etc. I mean, for glucometer. We have built an ecosystem of such devices across the country and use the non-invasive devices, which is very important for kids, especially they don't want to be pricked. Also, we have developed games our own for mental wellness that actually looks at their attention, their memory, etc. Those are our IP. These are the differentiation for than anybody else doing the health screening. So your deliverable is the tools and diagnosis tools? Yes, yes. Talk more about that, because this looks like more like a entry management system. Sure, sure.
And do you have an app and a cloud?
Yes, we have an app in the cloud and the parents get access to it. For GDPR and privacy reasons, the data is only available to the parent. Nobody else get access to the health records of the kids.
Sir, how is the effectiveness measured? Because as a public health specialist, what I understand that anything, if you want to see the safety or the effectiveness, you have to do an RCT. I mean, there should be a proper trial. We talk about technologies, but then we don't do some proper trial. There should be a control, there should be a intervention arm, there should be a process evaluation. That's why the technologies are not like incorporated in the system, because we are like our medicine that is based on what do we say, evidence based things.
Yes, ma'am.
So I really feel that thing, the implementation research is lacking in the technology section, what I could hear right from the morning.
Sure. I think let me clarify here, ma'am. We are not replacing the doctor.
No, I'm not talking about it. You give us proper evidence.
Yes.
That's what I'm here
So
asking.
this is the approved process that RBSK or WHO does for health screening in schools. Across the world, we have looked at the best practices and that is what is incorporated into this flow. So it is exactly what is required by NEP, required by WHO for health screening in schools. That's the flow that we are using, ma'am.
I believe you have a screen around 200 schools. Do you have the data? What was the finding and
Yes, sir. So, yes, sir. So we have found more than 30% of kids having dental issues. We have found more than 25% of them have anemia. We have people with 10 to 15% of kids who didn't know that they had a vision issue. So, I mean, a lot of people wear glasses, but then 10 to 15% of them didn't know that they were having vision acuity issues. So that is our finding, sir.
and the psychological problem, ADHD?
Yes, sir. Yes, absolutely. Mental wellness, we have seen a lot of issues, especially when the kids play the games. They are looking at, okay, they think they are playing a game, but then we are able to identify ADHD, memory wellness issues, cognitive issues, hand-eye coordination, all of that. Sir. Thank you.
Thank you so much, sir. The last presentation for the day is from XClick 3D.
Hello everyone, I'm Dr. Vinamra Jain, a practicing endodontist on weekends and a biomedical innovator on weekdays. 2 lakh dental practitioners in India every day have to play a game of hide and seek inside your mouth while doing routine procedures like RCT and extraction. Why? Because the cost of the treatment is so low that a 3D scan is not feasible. Now, many dentists are skilled enough, they are able to see the 2D X-ray and get the 3D anatomy. Many dentists, they can have failures and it won't matter to them, but the 5,000 new dentists passing out every year, they do not have that luxury. A single spoiled case can ruin their career. So, in this situation, I am developing a software, XClick 3D, that can convert the 2D X-rays that are taken in a dental clinic to 3D volumes using statistical shape modeling and generative AI. Plus, the best part, the dentist does not need to buy any hardware. his existing dental machine will be enough for this technology to give him a 3D scan that will help him in doing the routine dental procedures. Thank you.
In a regular CAT scan, if I want 3D reconstruction, I can get it done. So for instance, if I'm going to do rib plating for refraction, or I have to call the radiologist and he gets, where is AI coming into this? This is not CT, this is
Exactly.
but where is AI coming in?
Exactly, sir. The number of projections, the number of X-ray projections that are being used for reconstructing images is very less. It's almost 3 or 4 X-rays, because when you are doing an intraoral X-ray, so the film is inside the mouth, and there are very limited angles from which X-rays can actually be taken. And that is where the novelty is.
So, nobody has done this before?
No, sir.
Sounds unique and interesting.
Thank you. Yes, sir.
Level is too less for a business model to scale up. Why are we keeping so low? Is it innumerable 3D at 1,000 rupees or is it per?
Yes. Innumerable 3D is at 1,000 rupees. Because I feel that this technology needs to be the change that navigation technology has brought to transportation. It has given rise to startups like Uber and Ola. So I want this technology to reach that level. So for that, it's necessary that it's used extensively.
Is it a patented technology?
Not right now, it's under development.
You still develop?
Yes.
And I mean, what's the plan? Like, how do you plan to do what's the phase-wise plan to export this?
Right, so right now we have trained the model on processed data from the imaging centers. We have CBCT, retrospective CBCT scans from imaging centers. We are simulating 2D X-rays on them, and we are training our model. We are slowly moving towards more raw data, and by the time we have a good enough model to work with a patient's X-ray, we'll be going for its validation in the dental academic institutions as well as the laboratories. Yeah? Myself. Yes, I am a dentist and MTech in biomedical engineering. Yes. Thank you. Thank you, sir.
Thank you so much. I hope you had a few interesting ideas, thoughts, startups, and projects that you witnessed today. To take us to the next session, I think we'll slightly tweak the program. And I would like to invite a few experts on the dais to have a short discussion about some aspects that have come out on basis of the discussion that was held today. I would request Dr. Kar to be, please come on the stage, sir. Dr. Sujendra Rao, please, if you could join us on the stage, please. Dr. Venkatesh Iyer. Dr. B.S. Satya. Thank you. Dr. Puranik, if you can also please join us, sir. Thank you so much, sir. Very warm welcome to all the dignitaries on the stage, and to all those who are sitting off the dais. I hope we are keeping the discussions engaging in us to avoid any sort of drowsiness. In case you feel so, please ask for a quick cup of hot tea and coffee. As we have had multiple roundtables in the first half, multiple discussions in the first half of the day, followed by a lot of startups and projects displaying what they have built at their respective stalls, and a small demonstration or a discussion about what they are doing here on this dais. I think I would like to take it forward with some concluding remarks from all the experts on the stage on basis of what we have discussed today, sir. To start with Dr. Kar.
Okay, you go first.
I thought you had the mic, I thought I'll start with you itself. Sir, we have certain technologies which obviously almost all of them are at a very early stage of the development phase. At the same time, we have some startups wherein at least a proof of concept is there. In some of the cases, they have very early users in form of doctors or patients in some cases. In startups, they have some licensing requirements also, which some of them have gone through. Obviously, they wish to go much beyond what CDSO has given. They want to go for C, FD, etc. What are your thoughts on what are the ideal next step that a startup in general should take to progress at a much faster pace, part one? And secondly, how can they actually interact more with clinicians and users apart from the formal channels of licensing, etc., where it is always a part? Any thoughts there, sir?
Yeah, I'll answer first the second point.
Yes.
This, when you think that the interaction, one should be prepared anywhere, doctors are busy.
Right.
Someone is going from the technology side, technical experts, what I have seen also in Jodhpur. When someone is going from the technology side, they should be prepared that I have to give some time. Like doctors are not so busy, I will go in 2 minutes, I will ask questions and I will come with the problem statement. That is not possible. You have to spend some time. Like even you are going someone OT, you spend the whole surgery procedures. Then you can know what is the problem that is, then you can write the things. That's the point, you have to give some time. From your technology side, those students or someone you are sending reference, they should spend time with the corresponding faculty in medical science. Not like you will go just like I do this project or some startup, I will go and asking the resident and coming back from the OPD, that will not. They have to spend time and find out the time when the doctors are busy. I cannot find the exactly problem statement. I have to spend time. That is the first point. Second point, what you are asking, that's how we'll take it. So you have to first, like any project, we are developing one questionnaire. So that questionnaire start your project build up. So you have to start that questionnaire, what is the need, what is the problem we are actually facing, like I am facing problem. I will say.
Yes.
This is not like ask, I will write one question, finish. That point should be there. Next phase, suppose they jointly you should go, this is suppose some technician is telling I will develop this part. Then how it is fruitful to you, whether it is solving your problem. That joint collaboration is not coming up.
Got it.
Because once this is a one-point contact, then they develop everything. That should not be. This is the phase-wise, they should regular interaction, this is the problem, whether we are going in the right direction, that feedback should be there.
Got it.
That is the point. Then coming to the first point, how these startups go next level.
Yes.
See, this is always I told, this is the starting is half done.
Right.
Then you will take into next level, means you have to do, this is like this doctor was asking, you should make it evidence-based. You have to go into the clinical trials level. Then you have to establish this is actually the fruitful things.
Right.
Then with your possibilities like we will go for clinical trials, establish, then we will put into the market. These are the way we have to proceed.
Right. So
every point we have to give you the regular instructions. Then you can do.
So as we say in the startup terminology, that have empathy with the user, understand what the problem is, and perhaps spend more time with them instead of just barging with the technology.
Because most important, you are developing for end user.
Yes, sir.
Suppose as a doctor I am not convinced, then how can I take it to the next level?
Right.
This how I will be convinced means regularly. Suppose my problem should be this. Whether you are developing or not, I don't know. Once you have taken the data, you are developing. Like what we are discussing the thing points.
Yes, yes, yes.
This is how you are doing.
Yes.
That's why everything should be clearly. That will be very good.
And sir, based on our interaction today with several doctors that were part of the first half as well, I think many of your colleagues are more than happy to work with technologists. This is something that my startup founders, my technologists did not know before coming here today. They thought that doctors are not open towards technology, but I think more than open, some of them have actually developed their own models already, and now they want to work with developers to take it forward.
Many things have, Dr. Punanik is also a surgeon, I am a surgeon, so many things people are there. We innovate so many things on the table. Like I am telling, simple, long needle, needle tip, what we are using. I am just giving an example. We are using for the cutlery purpose. This is not available. What we are doing, like the wire sharpening, everything. We are importing the same thing from outside, it's so costly. So many innovations. We do ourselves, because you don't know who will do outside.
Right.
There's a thing. So many things are there, there's an example.
as a part and parcel of your, I mean, duty.
Because
to
we need the
right.
quality service to the people, we have to develop our innovations. If someone is there, this will be better.
Right, understood.
That's not like it's a one day. Suppose someone you are coming, the whole surgery will take 7 hours, 8 hours, like onco surgery. Someone 3 hours, 2 hours. You will not spend time. Then how can you know that what we need?
Right.
Like someone suppose having the severe bleeding in the during operation. I'm giving examples because
Yeah.
then that point I have to identify the bleeding points.
Right.
Then if you will come to know this understanding, these are the problems, something you may technologically you can develop the idea. And whether this will be effective or not, I have to give my feedback. Like these things, there should always a time is important. You have to interact with each other. That's very important.
Got it. Thank you so much, sir. So, sir was already part of the panel in the morning. I'll come to B.S. Setya, sir. Sir is CMHO of District of Indore. Sir, when we talk about our entire district, and because Madhya Pradesh overall had been a Bimari state, has come out of that in the past decade or so, is progressing rapidly now. What technology innovations do you think would be required on the ground when we talk of primary healthcare level and not tertiary? So that is where I think I would love to have your input, sir. And do you think any startups that we have on display today, some of them have on POC devices ready, would be relevant to this? Or do you think that with various funding, because I have discussed with a couple of other people, with funding coming from the World Bank and other places, some of the requirements are already met, which the startups are developing today, perhaps because again, they're not connected to the ground as such, as much as they should be.
सर मैं डॉक्टर B.S. सत्या CMHO इंदौर हूँ। प्राइमरी लेवल पे अगर हम लोग देखे जाए तो हमारे यहाँ पर सबसे बेसिक कड़ी जो है हमारी आशा कार्यकर्ता होती है, सेकंड वन ANM रहती है, थर्ड वन इज हमारा CHO है, देन मेडिकल ऑफिसर्स PSC लेवल पर। चूँकि आशा को अपना एक टोटल पर्टिकुलर एक एरिया दिया जाता है 1000 की पॉपुलेशन के आसपास, जिसको एक गांव या उसमें कार्य करने के लिए उसको ऑथराइज है। वो अपना कार्य करने के साथ साथ ANM के साथ उसका पूरा हेल्थ डिपार्टमेंट के जो भी हमारे इनिशिएटिव्स वर्कर रहते, चाहे वो वैक्सीनेशन का हो, चाहे हमारा NC चेकअप का हो या हमारा नेशनल प्रोग्राम्स हो, इनको वो इम्प्लीमेंट करने के लिए भागीदारी रहती है। थर्ड वन हमारा तो CHO जो है आशा का और ANM के साथ कोऑर्डिनेट करके, साथ में कोऑर्डिनेट करके इन कार्यक्रमों को पूरी तरह से वो इम्प्लीमेंट करते हैं विलेज लेवल पर। हम बहुत सारी चीज़ें देखते हैं कि जो हमारे ऐप्स अगर आए हैं, जितने भी ऐप्स आते हैं वहाँ पर HR के हम लोगों को बहुत प्रॉब्लम्स रहती है। अगर फील्ड लेवल पे देखेंगे तो HR की प्रॉब्लम, पॉपुलेशन उन लोगों को 5-5, 10-10 हज़ार का दिया जाता है। उसके अलावा वहाँ पर जो कार्यक्रम इनको इम्प्लीमेंट करना है तो उन लोगों को एक स्केटर्ड एरिया है। अगर हमारा प्राइमरी हेल्थ सेंटर की बात करेंगे, स्केटर्ड एरिया है, तो वो सब चीज़ें नहीं हो पाती हम लोगों का। फिर भी हम लोग एक दूसरे से या टीम बना के और NGO से या कहीं से भी काम कराने के लिए उनको नंबर ऑफ द डेज का बढ़ाना पड़ता कि इम्यूनाइजेशन के डे है तो वो बढ़ा देते हम लोग। PSC लेवल पर देखेंगे कि डॉक्टर्स को जो है मेडिकल अपना वर्क के अलावा मैक्सिमम दूसरे वर्क करना पड़ता है।
एडमिन रिलेटेड,
हाँ, एडमिनिस्ट्रेटिव वर्क हो गया या कहीं पर हमारा डॉक्टर्स की कमी है किसी CHC पे, कम्युनिटी हेल्थ सेंटर पर, तो उस डॉक्टर की ड्यूटी वहाँ लगा दी जाती है। उसकी वजह से भी हमारा प्राइमरी हेल्थ सेंटर का जो वर्क है वो इफेक्ट होता है। या हमारा डॉक्टर कभी कभी MLC या पोस्टमार्टम में काफ़ी बिजी हो जाता है। इस वजह से भी हमारा मेडिकल वर्क काफ़ी डिस्टर्ब हो जाता है प्राइमरी हेल्थ सेंटर पर। तो ये हमारा बेसिक चीज़ें हैं। कई बार हम ये डिवाइस जो हम लोग जो बात कर रहे थे कि ये ला कर दें, मगर गवर्नमेंट में मैक्सिमम चीज़ें फ्री है। कोई भी चीज़ अगर आप लोग उसको अफोर्ड कर ही नहीं सकता, चाहे हमारे गवर्नमेंट के कम्युनिटी हेल्थ सेंटर हो, चाहे सिविल हॉस्पिटल्स हो, चाहे हमारा डिस्ट्रिक्ट हॉस्पिटल हो, वहाँ पर उनको कोई भी पेमेंट करने का नहीं है जी। तो जीरो बैलेंस पे आपको जाना है। और इसके अलावा अगर कहीं अगर व्यवस्था है तो आयुष्मान भारत की व्यवस्था है, जो आयुष्मान भारत में हमको 5 लाख की उनको जो फैसिलिटीज दी जाती है वो भी ट्रीटमेंट पार्ट दिया जाता है जी। तो इम्प्लीमेंट करने के लिए जब तक हम लोग सर सारी चीज़ें ये कर लेंगे, देख भी लेंगे, मगर बेसिक चीज़ें जो ज़मीनी हकीकत कुछ और ही है,
ओके,
उसको जब तक हम लोग बूस्टअप नहीं करेंगे हम लोग पूरा ठीक नहीं कर सकते। क्योंकि कई कार्यक्रम होते हैं, एनसीडी का एनसीडी कार्यक्रम हो गया, चाहे हमारा डायबिटिक हो या कैंसर वाले कुछ भी कार्यक्रम से अगर रहेंगे तो ये सारी चीज़ें रहती है, क्योंकि हमारे वर्कर्स को ओवर बर्डन से होता है, तो ये सब चीज़ें नहीं कर पाते सर। तो फील्ड में काफ़ी प्रॉब्लम्स तो आती है, मगर फिर भी जितना हम लोग कर सकते हैं। और इंदौर का हम लोग देखें कि इंदौर जिले का रिफ्लेक्ट होता है हमारी स्टेट पे, और स्टेट से होता है हमारा नेशनल लेवल पे। तो इंदौर जब भी करता है टॉप पे करता है, फिर भी हम लोग कोशिश कर रहे हैं कि गागर में सागर टाइप का काम करें हम लोग, कि जितना मिनिमम में मैक्सिमम जितना आउटपुट दे सकते हैं। इसके अलावा हमारे पास हमारी टीम्स वगैरह हैं, मेडिकल कॉलेज, अरविंद मेडिकल कॉलेज से भी हमारी टीम मैडम्स है, अक्सर हमें सपोर्ट करते हैं कि किस तरह से कहाँ पर कौन सी चीज़ को इम्प्लीमेंट करना है। तो एनजीओ वगैरह या हमारे जो पार्टनर वगैरह है उन लोगों से हम लोग कोऑपरेट करके बढ़िया करते हैं उन लोगों को, फिर भी हम लोगों को मैक्सिमम कोशिश करेंगे हम लोग।
Thank you so much, sir. I'll come to Dr. Venkatesh Iyer now. He is the HOD of Pathology at AIIMS Delhi. Sir, very warm welcome.
Thank you.
Sir, a quick question to you. I see that a lot of my startups and developers come with solutions in pathology, radiology, mostly based on AI. Some have ML to get in a security feature or to save a lot of data. They will use blockchain very often. At the same time, when I go to a slightly modern, updated hospital, I would see such machines wherein everything is being already done, be it radiology machines or pathology related machines, right? So where do you think that the startups come into the picture? Is it only at the lower end of the spectrum, wherein perhaps they need to be at the point of care or in rural, suburban settings where the population does not have access to best technology? Or do you think these folks can also target the existing gold standards out there, the machinery that is being currently imported or perhaps manufactured by the larger players?
Okay, so you have raised a large number of issues. What I would say is the main target for the kind of technology and the kind of startups which I saw in the afternoon are ideally suited not in diagnostics but in screening tests. So your criteria for a screening test are much lower than your criteria for a diagnostic test. Suppose it is glucose. Your aim in screening is to say that the glucose is too high and at a time when it should not be.
The trend basically.
Okay, so it is not that important whether it is 140, 160 or 180 if it is 2 hours postprandial, if you get that information. So diabetes already has large amount of technology available. So if you go for an area where you already have, optical coherence glucometers, you already have polarity, optical polarization based glucometers, you have infrared sensors for doing glucose measurement. There it is already well researched area. But something like anemia, we are having, somebody was talking about millions of children who are anemic, who are going to have underperformance. These are the kind of situations where if you just say that, look, this hemoglobin is lower than normal, he needs attention, or he needs something simple like deworming and wearing shoes, can make a big difference. I was also very impressed with the point which the previous speaker made, that the ASHA worker is the person who is most believed by the people in the village. Some of the technology which we are talking about should be to empower the ASHA worker with some detection methods by which they can do health measurements, so that, right at the village, a method to measure anemia, diabetes, or other, say, dental caries, or whatever it might be, this empowerment will make the deliverable from the ASHA worker much higher. And it will also enhance his or her credibility, and at the same time maybe give them a chance to earn a little more money than the pittance which the government gives them. So I feel that the startups should focus on the area where they have a strength, and that strength will always be the under-delivered, under-catered market of India, and rather than try to compete in areas where off-the-shelf technology is already available. So that's what I would say.
Thank you so much, sir. I'll come to Dr. Sujendra Rao, sir. Sir is a scientific advisor at Organization of Rare Diseases in India, known as ORDI. Sir, most of the solutions that I see and being part of the startup community for almost 5 odd years, I see a lot of solutions at multiple places. Very few of them actually target rare diseases, primarily because of the niche market. And when we talk about startups, people talk about millions and billions, right? So where does the entire startup and technology developer comes into picture when we talk about rare diseases? Also, is there any way, government, non-government, wherein we can promote the startups to work more in this sector, and any business opportunities that you see which are perhaps not visible to us as an outsider? I would love to hear your thoughts on that, sir.
Yeah, thanks. Actually, given the genetic diversity in India, we are literally sitting on gold mine, actually, in my opinion, and we are not encashing it, and we are not doing a good amount of job to help the community as well. So it is it goes either way. One is business-wise, we are literally just wasting the money. We are not understanding the value of rare diseases. And secondly, community also, there are a lot of people who are having these rare diseases. India is expected to have around 70 million rare diseases as per DBT numbers, 70 million. Okay. And we have a huge population. These people cannot afford all the 16 crore rupee drugs.
Yes.
We cannot. And that means to say that it is the duty for Indians to develop solutions for Indians. Okay, we cannot depend on other people to develop solutions for us. And it is, it's very glad to see so many, screening solutions are coming up. But rare diseases provide different kind of challenges and different opportunities as well. One of the things, just to say, goes from a simple thing. In the morning we were talking about electronic medical health record. You know, the amount of data that is just lost in the medical department of all the different medical colleges in India is enormous. If we would have just tabulated it in a very structured format, that data would have been worth millions of rupees, billions of rupees, you know. And pharma companies would die to get that much amount of data. Structured, organized, coded data. That is the first amount of money that you are losing. Because rare diseases, as you said, are very few.
Yes.
So, the numbers are very few. So how do you actually come up with a randomized control trial for it when the patient number itself is low, right? Then you have to come up with innovative methods of understanding the efficacy of the intervention. So one of the things that we talk about is natural history of the disease, right? So, and how many natural history of the disease case report we have in India? 450 rare diseases are recorded in India. More than 10,000 rare diseases are noted worldwide through literature analysis. 450 rare diseases. Give me one example where we have a proper natural history recording of India. One example I can give from NIMANS, where they worked on Lafora disease, and we have probably one of the largest database of Lafora disease neurodegenerative epilepsy cases in the world. And we have a great amount of information coming from NIMANS. Same thing for Wilson's disease, we have in NIMANS. So I'm sure in aims also we have, and that is the reason why government of Delhi is running 6 newborn screening for rare diseases here in genetic testing. So that means to say that's a large amount of work that needs to be done. That is one. First and foremost is understanding and recognizing the value of the medical data and the loss that is happening by not acting on it. That is most important. Okay, that is the first one. And second thing is coming up with these innovative kind of clinical trials, right? Like natural history of the disease, like, or you take digital twin, for example, where it is, if you, and the limitation is the technology. It depends on how deep and wide your sensor base is. How many how many characters and how many kind of different biomedical parameters you are capturing. Right? Like somebody said they have put 16 sensors for gas analysis, like volatile gas analysis. Well, we can actually use those particular things and see whether any of those make any clinical sense, and then try to transfer that particular technology for medical product development. Those kind of things. So.
Got it. So I think when I say it's a small market, I think I am mistaken, because rare diseases incidence might be low, but when we multiply it with the population of India, anything and everything is a big market opportunity by thinking on pure economic terms for a startup founder to survive and perhaps grow. And I think I would rather encourage the existing and newer startups to think in that direction also, that rare disease is something wherein research, data, both of them should go hand in hand, and whatever data we have in form of metadata collected through ABHA and the ASHA nurses should go into the entire stream of things and see if that makes sense in any which way. Perfect. Thank you so much, sir. I'll come to Dr. Puranik. Thank you so much, sir. Sir, quick question. We see certain solutions wherein people are trying to save during the golden hour after a trauma incident. Right? What do you think are the core technologies which should the startup sitting here and outside come up with, such as to increase the chances of survival, part A? And secondly, let's say if I can use that word, faster healing, or perhaps getting onto the road of recovery.
Okay, I'll come to your question later. Let me tell what I want to say and let people listen.
Sure.
Okay, so I need attention of the people who are talking behind and gossiping there. Okay, so you know what we are practicing today is going to change in next 10 years time. Okay, we are going to like more automation happening, more point of care devices will be available, and everything going to be non-invasive. Like you remember the story of a Kodak which has gone to the, blew off. And if they have not adapted the technology. So I see a very bright future for the community doctors. And all this point of care devices and screening devices is going to be a fantastic tool for the country like us, where community doctors are going to play a larger role. I can tell you, if anybody has got a future, is the community doctors. That's what I feel. Second thing is, we've been talking about like funding and all that thing. The funding comes as a problem. This is the high time that, of course, we are doing that, the technology, the engineering people and the medical people interacting and twin sharing basis on PhD and innovations and degrees awarded like that. So ICMR can come forward for the research grants and funding all those innovations. That will be a kind of a good thing. And let me tell you, in tomorrow's operation theater is going to be a different than what is today. There are going to be a data scientist, there will be a programmer, there will be analyst, there will be image analyst, there will be a biomedical engineer, there will be a genetist, there will be surgeon, anesthetist, and all those things. So things are going to change what we are practicing.
Sir, if I may interject for the audience.
Okay.
I think what we see in sports today will happen in medicine tomorrow. So sports is not only about players playing today, it is about biomedical engineers working today, data analysts.
Exactly. So the medicine is also going to happen that way. I forgot your question. Let me come back to, related to the trauma, how we are going to use in emergency rooms and all that thing. This point of care tools are going to be, I think, we are going to really adopt it. And because all this reports will be available instantly, so that is going to make a lot of, save a lot of life by making an instant decision. That's what matters. It's all about that magic golden hour time and that magic decision. So this is really very, very possible with this point of care devices. Having said that, in today's software time, everything should be rather camera monitored, And especially in India, what I feel, how your doctor is interacting, how your health worker is receiving the patient. Everything should be monitored at all the levels, so that those what we lack is a soft human skills, let me tell you, still in the medical industry. Having worked abroad a little bit, I felt that this is my prime area of concern. And we should be taking up this project through all these innovations and industry solutions. This all I have to say.
Thank you. Thank you so much, sir. Yes, please.
See, when you are asking like a trauma golden hour.
Yes, sir.
This is the, you develop simple app that is that region, how many hospitals, how many ICU beds, all these things are there, right time to right place you can place. Suppose some accident is happening here. Everyone think that I will take to the aims.
Right.
The aims is no bed. But simultaneously other hospitals they are lying in the vacant bed. That golden hour you can save by this simple app. You can put all the hospital this time, that at this moment, how these are the things. And people are now in a way, they are developing.
I think we did something similar during COVID. The government tried to, it was not, real time, but they did try. But post that we left it, let it be.
There's the for trauma special.
Got it.
Because some patient is coming here, no bed, then they will move another hospital. Like
They have the facilities.
The first one, they should start like we are seeing the restaurants.
Yeah.
This is everything should be in there because of maximum hospitals, they are now digital.
Yes.
Like in private hospitals also. And with all the Ayushman Bharat, every state they are having the health policies. They can give treatment initially there. That's why you should first, time consuming, that should go in the right place, right time.
Perfect, got it, sir.
That's one thing. Second point, just to monitor, what is he telling? Every moment, some device should be there, they should monitor and give to the patient. Suppose someone is in contact with the doctor, suppose someone is in contact with me, someone coming with, the parameters I am just monitoring. How can I monitor throughout?
Yes, sir.
This thing. And entering here, simple thing. Suppose entering into the hospital in emergency ward. How they will know that you are serious? So many serious patients are there. How you will be in touch with the right patient? Every moment you need the technology help.
I think the camera angle also comes into picture there. When you have real-time data available.
What we are thinking in technology point, you think may different.
Right.
That's why what I am telling you. That's the point you go. Someone should spend some time in emergency. They can develop new ideas. This, yeah.
So that's like in manufacturing, we used to spend time in the industry, multiple days at an end, just to see what does go wrong and what solution do they need. It is not just data bits of ones and zeros of what needs to be taken care of. So you had any thoughts to share? Yeah.
How many of you are involved in developing a database?
Is anybody
just a
involved in-
simple question. How many were? No, you are doctors. I am involved. I am not telling that I am involved. These people, they are telling about all the data, everything. How many IIT or technology people that are involved in developing a hospital database? Is there any availability? Because many people when I asking, they are not. Individual department, I will think specific, I will develop this database. Because data is the man. Data is the gold mine, what he was telling this, we are sitting on this rare disease. Jodhpur is also a center for rare disease. This all total rare disease centers, 9 centers is developed by the government of India, rare disease centers. That rare disease, there is in data, centralized data. There's those centralized data, what we are missing, how we are missing, and what can be done. This is analysis.
Right, got it.
One more line.
This is
Can
things,
I add one more
Sure,
line?
please,
Okay,
go ahead,
okay.
sir.
So, like all this invention and innovation,